Olá, bom dia a todos. Meu nome é
Hello, good morning, everyone. My name is Natalia Cumenali. I'm a journalist and I specialize in health. I'm also CEO of Futuro da Saúde. It's a pleasure to be here with you at the invitation of the Hospital Israelita Albert Einstein to moderate this event. Today, we are here to talk about quality and hospital services. Do you know what hospital quality is? It might sound broad and subjective, but actually, quality within the healthcare system is measured based on very objective criteria. Quality doesn't just have to do with how satisfied patients are after a procedure or visiting the hospital. It also has to do with the backstage metrics, processes, engaging teams, certifications, accreditations, and so on. And within that universe, does the patient know what quality is? And that's what we're going to be talking about today. We'll start this morning and we'll have 4 panels. We'll have a very high-level debate with some highly well-regarded figures on the subject in Brazil and around the world. So before we start, to those of you who are watching us on YouTube, please send us your questions through the chat and we will ask them to our guests. And now to officially start our program, we'll begin our first panel. This first panel will be about safety and quality, 2 of the main topics that are discussed in healthcare in this country. With the advancement of science and medicine in the country, we have made great progress and also patient outcomes thanks to tech innovation, training sessions, processes. It's possible to take quantum leaps. But the experience of benchmark institutions around the world in healthcare show that in order to achieve that kind of level in safety and quality, we have to go beyond. It's not just about having state-of-the-art technology or a renowned team, although that is also important. You need a long-term journey focusing on building a strong internal culture and robust processes that can foster the engagement of healthcare professionals so that they can operate with quality and safety. So that is the question of our first panel. What really makes a hospital safe and providing high quality services? And to debate those topics in depth, I'd like to welcome Dr. Miguel Cendoroglo, who's the medical director and premium care at Einstein Hospital, Mr. Pedro Delgado, VP of the Institute for Healthcare Improvement, IHI, Ms. Karen Wentzel, Senior Analyst at Magnet Recognition Program, and Mr. Heleno Costa Jr., the Superintendent of the Brazilian Consortium of Accreditation and also a member of the Joint Commission International. Welcome. I hope you're excited with our morning. And to start, this is how the panel is going to work. I have questions for you, and we hope to have an in-depth look at some of these topics, always thinking about the patients who are also joining us today. My first question is to Pedro. Pedro, to put things into context about safety and quality, how do benchmark hospitals around the world work on their quality and safety journeys until they can get to their current levels?
Natalia, thank you. It's a great question. Let me just make sure we start with the basics. When we say safety in healthcare, because we have patients on the line and they're the people that we are guests in their lives of, it's important that we make language very simple. So safety in healthcare is about preventing harm. The intent of healthcare is always good. People train very hard. Institutions equip themselves as well as they can. Teams work in the best possible processes, and still we get it wrong more often than we would like to. So safety is about preventing harm. There is an estimation that about 23% of every hospitalization results in at least one adverse event. Okay, that's from the latest study in 11 hospitals in Massachusetts. So this isn't something that only happens in countries like the country I was born in, Venezuela, the country I live in, the UK, but also in the country that you all live in, which is Brazil. So safety is about preventing harm, and safety is a dimension of quality. Quality in healthcare has 6 dimensions. Safety is one, which is about doing no harm. Timeliness is about ensuring that services are provided in a timely way so patients don't wait longer than they need to. Effectiveness is about doing what you promise. Efficiency is about not wasting resources. Person-centeredness is very relevant to this conversation. It's about ensuring that we first ask patients what matters to you. And then the last one is equity. So that's quality, and safety is a dimension of quality. Now, Natalia, to the specifics of your question, safety is a moving target. We will never, and let's be clear on this, we will never be finished with our work in safety. We will never be finished with our work in quality. And for that reason is that we need the voice of the patient to be active and present in the conversation, for patients to feel like it's okay to ask questions of their healthcare providers. What are your rates of infection? What are your rates of harm? How can we help as patients to ensure that those are ever improving? And how do you compare to others? So the best hospitals that patients can have access to tend to have a characteristic, and that characteristic is transparency. So they tend to transparently offer their rates of harm, because they transparently share them inside the hospital so that they can learn. Behind safety is a spirit of learning, and behind learning, there's a possibility of improvement. And in that spirit of learning and in that possibility of improvement, we need every single patient to be activated in order to help the health system be as good as it can be. The best hospitals have transparency. The best hospitals have a formal structure for patient safety that usually has a leader, and where every clinical team is deeply engaged in that exercise of learning every day and every week about what happens, and where preferably there's also a patient representative, a patient and family representative in that structure, in order to ensure that that structure has the voice of the patient present in their discussions, and it doesn't become a healthcare-centric discussion, but it's a humanized discussion, which is about preventing human harm. Natalia, to start, I would offer those quick reflections. I know you will have plenty more questions, and I'm really excited to hear what Heleno, Karen, and Miguel have to share.
Certamente tenho mais muito.
Yes, I definitely have lots more questions and the challenge to ask you all of them in this panel. Our next question is to Karen. Karen, before, I just want to have an overview of what Pedro said. Pedro said that safety is about avoiding harm. He said that 23% of all hospital admissions result in one adverse event. And he also said that safety is not static. It has to be changing, and it has to be fed and feed hospitals. And he talked about how important the voice of the patient is. So my question to you, Karen, is what is the role of accreditation organs and agencies in quality and safety?
Yes, thank you, everyone out there watching. I'm happy to be here and happy to represent the Magnet Recognition Program. So quality and patient safety, of course, Pedro was absolutely correct in everything he said, and transparency and collecting and monitoring data for what we call patient outcomes, but what the patient may know as complications or things that happen to them, those adverse events that occur in the hospital. One of the key providers is nursing. So nursing is responsible for direct care delivery in the hospital as part of that team that takes care of you, the patient. The magnet recognition that hospitals receive, whether it's in the US or it's international, doesn't matter what country, we have the same standards that must be applied. So when you see or go to a hospital that has a magnet designation, they have completed and are abiding by the magnet standards, which are focused on patient safety and improving and ensuring that patients have useful outcomes and that they are moving in the direction of improvement, getting better, decreasing those potential adverse events. So magnet requires nursing to monitor what we call nurse sensitive indicators. Now, what those are where the nurse takes care of patients in that delivery of care where you have the nurse at the bedside. Those metrics or measurements where the nurse impacts the most. So that what Pedro was talking about as far as monitoring and measuring, that's a requirement of magnet. So the magnet recognition program requires ongoing magnet standards to be monitored throughout their designation period for that 4 years. So that goes to transparency as well. So the magnet designation for a hospital or a healthcare organization is one of the most prestigious credentials that a healthcare organization has. It says to the patient that we have nursing care delivery excellence here. We report our measurements and we abide by standards that improve patient outcomes and decrease adverse events. Nurses are involved in decision-making and collaboration, and the organization supports nurses so that they can provide care at a high standard. So all of that feeds into the healthcare team that Pedro was talking about, the nurse, the physician, all the other services.
Excelente.
Excellent, Karen. Thank you so much for that introduction to the topic. We will be taking a more in-depth look at the role of nursing and these accreditations, which are so important in the context of health and safety and quality as well. And now my next question is to Heleno. Heleno, in this first round of questions, we want to take a look at this topic, and I'd like to hear from you about the role of accreditation organizations, about quality, as Karen said, and Pedro said, but in the Brazilian context, how is that seen here in Brazil? Well, good morning, everyone. It's an honor to be on this panel. Thank you for the invitation. And I am really happy to see this element in our discussion, patients and their families. This is a very philosophical debate that has been ongoing for years. Patients, at some point in their life, will need the care of a healthcare institution. And today we're talking about hospitals. And that question has to do with the mission of any hospital. Pedro touched on that, so did Karen, to deliver the best possible product to patients. They come to hospitals expecting to be healed or to recover or to improve their health in some way. And the role of accreditation programs is precisely to provide a tool, a method that will organize, that will be putting processes into order. I don't like the word standardization because it sounds a little inflexible to my ears, but to organize, to put things into order through standards that are established by accrediting organizations through their guides. This has been spreading around the world, and I'm happy to say that the same is happening in Brazil. We have about 6 accreditation organizations in Brazil. They all have different roles, but they all focus on working on quality and safety management. It must be clear to all of us that safety and quality do not just happen on their own, because we're talking about high complexity environments in hospitals. There are many diversity, jobs, people, so there has to be a management process. And this has been increasing in Brazil as well. We have undergraduate and postgraduate programs focusing on that to qualify professionals to that end. So when we want to do something well done, and considering we have a toolkit, having the toolkit isn't enough. We need to be able to make the best use possible of those tools. And the accreditation programs, when they are properly implemented, which is also important, allows us to have the ability to improve quality, to implement processes to improve quality. We're talking here with Pedro Delgado, who's representing IHI, qualifying experts on improvement. And when we talk about positive change, that happens after 6 or 7 cycles of change. And accreditation plays a very important role. We still have a long way to go. The number of still falls short of what we can do. But, Natalia, there are Brazilian and international studies that show the positive effects of accreditation in terms of improvement in quality. And now we just need to put the patient at the center of it all, their families at the center of it all, in terms of what your final product is, healthcare, clinical outcomes, to make sure we're delivering the best possible. We've heard figures. Pedro talked about the lack of safety that is still present. We still have a long way to go, but we also have come a long way in the universe of accreditation programs. Magnet is fantastic, the largest service provider in nursing. I don't know if Karen knows that, but I'm a nurse as well. So there's also that accreditation. And accreditation in Brazil is an extremely positive element and quite consistent, I'd say. Thank you, Heleno, for your comments. And that goes to everything that has been said so far. And please, we have a question to Dr. Miguel. Heleno mentioned a very important aspect. Quality and safety don't just happen on their own. Just wanting to have quality and safety isn't enough. There's a journey. There's a journey that includes processes, and there has to be intent, and it includes accreditation and many other elements. My question is, what was that journey like at the Albert Einstein Hospital? When did you start thinking about that, and what have been your results? And you have the magnet accreditation, right? Yes. We're very proud to have that accreditation. That was the hardest one to get from ICAC. Probably the most demanding around, I think, actually. Very high level. Very few hospitals achieve the magnet accreditation. So we're very proud to have it, especially because it was completely led by our nursing team here at Albert Einstein Hospital. And thankfully, they are very empowered at the Albert Einstein Hospital, and we're very proud of that. I'm very happy to hear you say things the way you did, Natalia, because it is a journey. And I'd like to tell you about our journey because it includes a number of people. The social fabric of healthcare organizations is made up of people. So we like to share Einstein's story because we've only had 5 chair people here so far. Believe it or not, Dr. Manuel Hidal, who was here from the very beginning, since the charity institution was created, the opening of the hospital, which happened in 1971. So it's a fairly new hospital, considering the history of other hospitals in Brazil and around the world. So when the hospital was founded, they already tried to attract talents, created their principles, and in the original documents, they already talk about patient safety, the importance of knowledge. We finally have a medical school as part of our system now. We have also a nursing school. We've had that for a while. And then we had Dr. Fair at a time when technology made all the difference. I joined the hospital in '91 with Dr. Fair. There was a medical team who had access to technology, and that made all the difference to quality. There was a sense of pride, you know, even vanity perhaps, because we thought our organization really did provide quality services. And that was all about around the world. We started discovering indicators, how important they were, and we realized that we could improve indicators and deliver even more quality. We tried ISO 9000, we tried different standards, total quality management. There were many different theories around at the time. And around 95, we heard about the accreditation programs. And we heard that there were established processes for that. We knew that there was a standard, and we knew that we had to have a minimum level of quality and excellence for each of those standards. So some of our leaders contacted the Joint Commission, and it's interesting because at the time it was called JCO, and it was based in the US only. And they thought it was strange that a hospital from outside the US wanted to get an American accreditation, and it was the only accreditation available at the time. So after a while, after 2 years, the Albert Einstein Hospital managed to get a mock survey. It was like an audit simulation. We thought we were going to do really well, and we did terribly. And then we realized how poorly documented we were, how little control we had over our processes, how inconsistent they were. So there was a revolution at the hospital within 2 years. The whole medical team was highly engaged, including independent physicians. So we practically reopened the hospital once we had the Joint Commission accreditation. That happened in 1999. They say it was one of the first hospitals to be accredited by the Joint Commission outside the US. And at the time, we had the Brazilian accreditation consortium was created. They've always supported all the accreditations. The consortium is led by our dear Heleno. And so this accreditation took us to a whole different level. And that was actually a stepping stone and not the final objective. And then in the noughties, we started to realize how important that was. We had the 100,000 lives program. We created process packages, processes that we could impact. So we've achieved improvements of up to 90% in many of our indicators, including hospital infection indicators. And over time, we've been learning, and we pursued other accreditations. We aimed higher and higher. And since 2013, this is our 10th anniversary of a strategic partnership. Pedro and I are heart brothers. And with IHI, we learned the importance of having other targets in addition to the levels we got to with our accreditation. We have over 15 international accreditations at Albert Einstein Hospital. And you could say we're obsessed about accreditations, but we don't just stop there. We have some more robust programs such as high reliability, which means 0 severe and catastrophic adverse events. Events where patients suffer clinical issues that might result in death. So to get to high reliability, you have to go through many principles. I won't go over them because we don't have enough time, but transparency is one of the main ones, and engaging not only the whole team working for the hospital in terms of care, not care. So nurses, physicians, administrators, focusing on safety and quality, but also engaging patients and transparency. That was famous in Brazil. A girl, unfortunately, I only got to know about it after she died. Her name was Juliana Lima. She was 27, and she died owing to a severe adverse event. It was preventable. It could have been prevented. And what we did, in addition to in-depth investigations and the implementation of measures to stop it from happening again, because that's what we do. We obsessively look for events and we obsessively try to improve. We created the Patients Committee on Patient Safety. It's called Juliana Lima. So we discuss all of our problems, all of our failures with full transparency. And the main lesson learned is that you cannot not learn from those events, and you can't stop improving. So that relentless pursuit of improvement, high reliability, is what makes us keep on going forward in our search for quality and safety. The journey itself and all of its learning, all of the baggage that it gives us is what makes us a hospital that makes people trust us. That trust comes from that higher purpose. And that purpose, it's quite short. I'll mention it because I think it's worth it. Values, principles, and purposes is where everything starts. When you create a culture of safety like the one we've been trying to build at Albert Einstein Hospital. Our purpose is to provide healthier lives through a drop of Einstein. A drop of Einstein means the excellence we would like to provide patients with through care, through knowledge, through capacity building to every human being. It used to be to Brazil, to each patient in Brazil, to each citizen in Latin America, to each citizen on the planet, and now we've changed it to every human being. Because those who are on a space station also are entitled to a drop of Einstein.
Thank you, Dr. Miguel. Always building higher purposes. To Pedro, I would like to discuss failures in healthcare. Obviously, when we talk about healthcare, failure is a taboo. Nobody wants to go through this. And in the answers you gave, you mentioned it might happen. So if you don't have processes, if you don't have accreditation, if you don't establish a target of understanding what is happening, there's a high risk of having failures happening. The question is, can we learn from the mistakes? Can we improve quality? How this analysis of adverse events mentioned by Dr. Miguel can help us to learn from the mistakes and improve healthcare?
Thank you, Natalia. It's important, again, because we're with the people that put their trust in our hands, that we start by describing a reality for all of us. We all want to be excellent. We all want to be great every day of our lives, in our personal lives, in our professional lives. And despite that, sometimes we fail. So the paradigm of failure is one that healthcare is not immune to. It's one that we should ensure that we accept, that we understand, and that we proactively try to make sure we have learning processes in order to address failures. So the first thing is to mitigate and prevent. So we prepare through accreditation processes, through ensuring we understand what the latest standards are for procedures and processes and so on, so that we mitigate and prevent. And then if things happen, which is something that none of us want, patients don't want it, healthcare teams don't come to work to harm anyone. Whenever things happen, they may or may not lead to harm. So sometimes you could have an adverse event that doesn't lead to harm, a medication interaction that had a mild effect on a patient, for example, or a drug that was prescribed erroneously but did not harm the patient. So some of these failures don't result in harm. The ones that do can be very mild, or they can be catastrophic, as Miguel explained from one case. And every hospital in the world has, unfortunately, gone through that. So addressing the failures requires institutions to have learning systems, and those need to be daily learning systems initially. So there are hospitals and institutions that embed something called a daily briefing and a daily huddle in order to sit down every morning and say, okay, good morning, guys. We're going to sit here for 30 minutes. Let's understand what harm might happen today in the hospital. And things like, we have two people called Miguel going to the operating theater. We have two complex surgeries happening at 9 o'clock and so on happen. So proactively, you're ahead of what could happen in the hospital. So having learning processes that happen every single day are ways to prevent. Then having instances where you review your adverse events from basic near misses, so when things almost happen, to deep root cause analysis, where you really go deep with healthcare teams and understand when something went terribly wrong. The important thing here, Natalia, and in partnership with patients, is that we take every opportunity we have to first prevent and mitigate failure by instilling daily conversations to be ahead of harm, and then to have processes to review retrospectively when harm happens. If we do that, there is a concept that every healthcare institution pursues that's important, and that's part of common language, and it's reliability. So what we're pursuing is reliability. We want to be reliably excellent. So we don't want failure to happen. We don't want harm to happen. We know that despite our pursuit of reliability, sometimes things will happen, but we are pursuing reliability so that things happen excellently every time, not just sometimes. Many institutions are very close to reliability, and hence their rate of harm is low. Many, unfortunately, remain very far from reliability, and hence their harm rates are higher. Okay, we happen to know Einstein very well, and we know their pursuit of reliability is a pursuit that's over 20 years long. So we know that's becoming part of the culture. You want that to be part of the culture. This is not the job of a patient safety team. This is the job of every clinician in the hospital, the job of every manager in the hospital, and the job, hopefully, of every patient that feels empowered to express a concern when they have it. Can I ask the doctor if they have washed their hands? Are you making sure that it's my left arm that you're operating on? So asking questions from patients is really, really important in order to prevent failure.
Thank you so much for your comments, Pedro. Heleno, connecting Pedro's words as to the culture, the daily learning process, I would like to consider the patient side. How can the patient know if an institution is going to have all these systems, all these accreditations? And Dr. Miguel talked about the history, how things have changed, how accreditation was obtained, and how things happened in Brazil. Do we currently in Brazil, do we have the culture of informing patients? This is a million-dollar question. Natalia, Miguel, and Pedro talked about high levels of reliability. And I believe that still considering healthcare, this relationship is unfortunately not mutual, is not shared. Unfortunately, our patients are laymen. They go into this environment, they don't have the information, they don't have the skills, they don't have the knowledge to discuss the options they are presented with in deciding what is the healthcare. In building a culture of safety and quality, I would like to stress the experience of the Albert Einstein Hospital. Dr. Miguel mentioned this, they were 5 CEOs of the Einstein involved. And the same happens to the accreditation systems, 5 different managers. Imagine what would happen if you had 5 different fathers during your childhood. So one point I would like to stress, leadership has a crucial role in building the safety and quality culture, especially the intermediate managers, those establishing the link between the upper management and the teams. Is very difficult for a patient to have access to a CEO, to a president of a hospital. So we have to build this culture of a reliable and transparent relationship between all stakeholders, all parties, and we'll be promoting, empowering the patient and allowing the patient to be informed. So disclosure, it's an important word. We have to be candid with family and patients, and in case of adverse events, of errors happening, we have to be very clear. And in the Brazilian culture, this is very difficult for Brazilians to admit failure. So very often this is a culture that happens at the institutions. We don't talk about failures, we talk about problems. So they even change how they name it. And we also have the culture of always trying to find the culprit for what happened, to blame someone, or even telling the patient's family, oh, that was that guy, that person was responsible for what happened, and we are going to terminate him immediately. So, considering the American experience and the experience of the NHS and of the National Safety Agency in the UK, and we have the reports of incidents within the notification system, the reporting system. In 2022, they reported more millions of incidents. So imagine the rate, the numbers. And the most important comment on the report is we are happy because we have improved this reporting culture, and there's still further room for further improvement. And one thing was stressed. So once we have identified this significant number of incidents, they were able to take action. So reporting system has identified the level of damage according to the level of damage, mild or serious damage. But the major outcome, the catastrophic event, the number of deaths was reduced. So this was stressed in the report. So this is publicly available. All the information is available, it's transparent. And this is exactly what we need in Brazil. We have to have a reporting system, not for everyone, for the patient, for the families. And I would like to be able to tell the patients and the families, when you choose one hospital, do the same as you do when you choose a new car that you are buying. You check the safety features. So check also the mortality rates, the level of incidents at that hospital. So if we have this information available, the institutions can be reliable. I love this proposal. So this might be a new step that will be taken in Brazil. Maybe our audience will understand that quality and safety are not just abstract words. They make a lot of difference, especially for the journey of the patient and for the outcomes for the patient. So this is connected to the next question I would like to ask Karen. Karen, we discussed many aspects of this quality and safety journey, admitting failures, the importance of accreditation, standardization, involving patients, knowing what's happening, and changing this culture. Heleno has just mentioned, we don't talk about the mistakes of errors, failures. We talk about problems. We always find someone to blame. And healthcare professionals, they don't want to be considered the ones to be blamed for. My question for you, Karen, is what is the role of skill development of the healthcare professionals as to this safety and quality culture? So what is the knowledge they need to provide?
Right. So education and training, you can look at it from two perspectives, 2 points of view. And one is training for being safe. So training the staff, that's all staff, from the nurses, the physicians, the other services like the radiology staff, the laboratory staff, the person who comes in and cleans your room, all receive or need to receive in the institution training about safe practices to keep the patient safe. And a part of that training is communication. And communication needs to occur amongst the healthcare team when we hand off patients to each other. For example, when the nurse is taking the patient down to another department or another unit when they get transferred, it is very, very important that that nurse communicate to the person that is taking over the patient all of that patient's needs. The patient also should be included in that conversation. They should not be left out. So if the patient is awake and able to talk, then that patient should also have the opportunity to be involved in what we call in healthcare a handoff. And that allows the patient not only to be involved in their care, but also share important information about what they might need, those things that may not be going right for them in their hospitalization, or what makes them feel good. We've talked a lot about patient safety and quality. One of the most important basic factors is to listen to the patient. And whether you're the nurse or the physician, that is the fundamental skill that we all have to improve, is be better listeners. And part of the training for patient safety in many organizations is to train employees or staff to listen to the patient and to advocate for that patient if the patient cannot speak up for themselves. There's actually a campaign that we have in the US called Speak Up. And that education is directed towards patients. And if they feel, and family members, if they feel that something is not going right with their loved one, or someone feels that way as a patient, to speak up, to speak out, to ask for the doctor, the nurse, to do something about what they are concerned about, to hear their concerns. There are also other programs that come from education that we have initiated, things like rapid response teams, where a patient's family member who is concerned about the patient but feels like they are not getting the care that they need, or something is going bad, they're very worried, they can pick up a phone or they can call the nurse to call a team of people to come to the bedside to check out that patient. That's been a very big improvement in the US and around the world to improve death rates, to decrease them, to decrease complications such as poor breathing, other things that happen to the patients in the hospital. You get a team of people there very quickly to look at the patient, or listen to the family's concerns so action can be taken more quickly, and thereby decreasing the negative things that can happen to the patients while they're in the hospital. So education is very important from the patient safety perspective. Another important focus of education is the staff education as far as their academic training and skills. So in nursing, I'll speak from that perspective since I'm with the Magnet organization that focuses on the professional nurse. It has been proven in the outcomes for patients that nurses with higher education and specialties, those patients that go to those organizations that have specialty nurses and nurses with a what we call in America undergraduate degree, and they are RNs, registered nurses, have better outcomes, meaning they do better than when there are nurses who have a more minimal education level. So you are fortunate in Brazil in that the requirement to be a professional nurse, a registered nurse, is a 4-year academic baccalaureate degree, and that's equivalent to the US. But in the US, it is not the same. So we have different education levels for our nurses. So Brazil has a requirement, so that is excellent. You also have specialty nurses in Brazil. such as nurses who take care of wounds, nurses who focus on diabetes. Those are specialty nurses. Those kinds of diseases and complications require a highly specialized person to be able to care with skills that can care for that patient population. So when you see a magnet designated organization or an accredited organization, there are requirements for including patients in their care. There are standards that talk about including patients in their care in the handoffs, such as Joint Commission and magnet accreditation. So that is one way that you can tell or identify when you go to an organization that there has been some training, that there has been some standards met because they are accredited or recognized in some way through a credential, that they, the staff there are participating. But ultimately, as we have all talked about on the panel here, is it's critical that the patient speak up, and that no matter who the staff is, the physician, the nurse, the radiologist, whoever, that they speak up and we listen. We listen in the organization to the patient. So education is critical, and part of that is all of this training that we do.
Karen, thank you very much for this answer. I think it's extremely clear, considering all the answers we got from the panel, the importance of the patient in this context. And we have to start looking at the patient with from a different point of view. And minutes left for this panel, I'd like to ask a final question for you and ask you to give a brief answer, thinking of our audience. We have patients trying to understand what is safety and quality. So what is being a safety and a quality hospital? Please, 1 minute for your answers. You are on mute, Dr. Miguel. Oh, it happens. This last point mentioned by Karen, not just development of technical skills, formal education of people, but also awareness, situational awareness techniques is very important. Especially being aware that you never will be able to control everything, not at Albert Einstein Hospital or at any other institution. And this level of awareness, it's important to be stressed during training. Oh, quality institution are based, they have the accreditation level, and they also have quality standards. We have the improvement system that qualifies people at different levels, and we want people to be all over the organization. We have the fellows, the top level, able to organize quality systems. We have at all levels, at the level, the primary care level. So we have to consider quality and provide consistent services. And this trickles down all the levels up to the level of patient interaction, hospitalization team. So it happens at all levels, and there's a decentralized system. And situational awareness is also related to self-reliability, healthcare, and especially hospital healthcare. It's important for people to understand, to be humble enough to know that we'll be never able to control everything at all levels. And this is very important for a high level of reliability. The more we admit that we are never going to be perfect, we obsessively want to be perfect. There is not one hospital that will be perfect. And this requires training, education, and quality and safety. This requires engagement of patients, engagement of medical teams, and is a journey. We build it step by step, and it's a never-ending journey. In Brazil, for all of us who are working with this, it's gratifying to know that we have been improving quality and safety indicators. We have gone through a lot. We are advanced when compared to a few decades ago. However, there's still a lot to be improved thanks to technology, and certainly new chapters will happen along this way. Thank you very much, Dr. Miguel. I would like to give the floor to Heleno for his final comments and to call the attention, especially to the topics the patients have to be aware of. I would like to mention two crucial points. Hospitals have to have all these aspects permeating quality and safety. However, they have to be welcoming for the patients, welcome not just the patients, but also the professionals working at the institution. And a second important point, according to my own experience, hospitals that have the best systems and the best structures are those who really empower and value the intermediate managers, those in the battlefield, working daily at all levels of the hospital. So the more you value these intermediate managers, the more you train them, the more you develop their skills, this will be a win-win situation, creating new possibilities for improvement, because these are the soldiers at the front line, the battle line. So with that, I would like to thank for this opportunity. Heleno, thank you very much. Karen.
Your mic is off. Yeah.
Yes, yeah, I got it. Thank you. Yes, so I would like to sort of piggyback onto what Dr. Heleno said, and that is, it is the culture and atmosphere when you walk into the institution for the patient, that they feel welcomed. They feel like people are interested that work in the institution in what they have to say. I cannot express it enough that it is about listening to the patient in so many different ways. One is about their own safety, but also in a way that they feel our compassion and our love, if you will, in their time of need. It's a very difficult position to be in, to be a patient that's in the hospital. And we really experienced the tragedy of being either a patient or a loved one of a patient during COVID over the last several years. It was tragic not only for patient populations, but for the staff taking care of those patients. So safety is critical when it comes to times, and I do believe we'll see more times where we are just overwhelmed at the front lines, as Heleno said, where it feels like a battlefield, but there has to be at the very basic level that we listen. And we sometimes are dependent on that patient to tell us what their need is and whether there is something going wrong. I always like to use the example of the mother whose child has been admitted to the hospital and is on the pediatric ward, and the child can't really speak up for himself. And the mother knows that something's wrong. And it becomes apparent to her that she needs to let the staff know. And when you encounter staff, whether it's the nurse or a technician or someone else that will listen and take action, you know you are in a good place. And that culture permeates throughout the organization. And as we all have pointed out, it is all about the team. It's not about one person. It is a healthcare team. And you should get the same message from everyone that works in the institution. You should get that same feeling. So that's really how a patient can tell if it's a safe institution. Sure, there's a lot of regulatory and accreditations and recognition, but it really comes down to the culture has to be there. Everyone has to be practicing the same.
Excellent. Thank you so much, Karen. I would like to give the floor to Dr. Pedro for his final comments.
Natalia, thank you. You've conducted this panel so well, and Karen and Heleno and Miguel, I have learned a lot. I'll be very brief. So for patients to know and remember, all the patients that are on this video call today, you are the experts, really. We are here to serve you. So make sure your voice is honored, your voice matters. So 3 things to look out for. 1, data on the walls. If you walk into a unit and there's data displayed and you can see it clearly and transparently, that's a really good sign. Secondly, you're able to ask questions. You're able to ask questions. People are receptive to your questions. And thirdly, you feel, and this is more of a gut feeling, empathy and compassion from the people that are there with you. I think if you have those 3 things, in addition to all the technical things that the experts today have described, you will be walking into an institution that is inspiring to be as safe as it can be. Natalia, what a great opportunity. And for all the patients, remember, your voice really, really matters here.
Muito, muito obrigada.
Thank you very much. It was a huge pleasure chairing this panel. I learned a lot from you. I'm certain that our audience has learned a lot as well. And thank you, Pedro, for this message. The voice of the patient really matters. The patient has to be inserted in this quality and safety process. Thank you so much. And now we are going to have the second.
E estamos de volta agora para
And we're back now to talk about the importance of quality indicators, how important clinical outcomes are to help us go beyond the hospital environment. It was very clear from the previous panel that guaranteeing patient quality and safety is key to the hospital environment. There have been many challenges, as you heard in the previous panel, and now we are going to talk about one of those challenges, indicators that allow us to have a broader outlook and that bring insights that go beyond those that are collected within the hospital. For instance, measuring clinical outcome indicators is important to know about the result of a specific treatment, if it had the expected result or not. But other ones, such as improvement in quality of life, patient experience, patient satisfaction, are equally important. And that's what we're going to talk about in this panel. So to start this discussion, which is going to be great, I'd like to welcome Claudia La Selva, Director of the Morumbi Hospital Unit and Care Practices at Albert Einstein Hospital, Mr. Jao Gandhi, Director of Safety and Transformation at Press Ganey in the US, Vanessa Tate, who's the Director for Healthcare Economics at Einstein, and Angelica Carvalho, who's the Deputy Director for Sector Development at the National Supplementary Health Agency. Welcome. It will be great to have this chat with you. So let's start. Before the first question, I just want to let everybody know that you can send in your questions through the chat box. I'll get them on my mobile phone and I can ask our guests your questions. Tejal, I would like to ask you to talk a little bit about context. What are these practices concerning quality indicators and hospital safety in the US? In the previous panel, for instance, we talked a lot about transparency. All of our guests mentioned transparency. So my question is, are data transparent?
So in the US, there has been a lot of work to create quality measures in the hospital setting and also in the settings outside of the hospital. And they generally have followed a framework that came from the Institute of Medicine with 6 dimensions, and I'll just mention them quickly. So safe, timely, effective, efficient, patient-centered, and equitable care. So there's these 6 domains, and we try to create measures of quality in those 6 areas. In terms of transparency, I would say we have some, but we have a long way to go still. So we do have ratings that you can see online from our government. Our government is the biggest insurer in the United States, Medicare and Medicaid, and they post ratings of hospitals and outpatient facilities based on things related to these measures of quality. So they post some of them, not all of them, and they also post data related to things like patient experience surveys. I would say it's not that easy for patients to go find that information, though. So that's when I said we have a long way to go. I think it's not so easy to do it. The thing that is changing now and happening in the United States is that more and more hospitals are actually posting their performance on their own websites. And so they will post the performance around patient experience scores, for example, on their own website, because they are trying to have good information for patients to select them, for consumers, we call them, before they become patients, to select that hospital or health system. So I would say transparency is coming. We are further than we were, but we still have a long way to go.
Já muito obrigada por trazer.
Thank you, Tejal. Thank you for putting things into context, because it helps us understand what's happening internationally so that we can also update what's happening here in Brazil. So this chat will be great. My next question is to Angelica. Angelica, we know that in So ANS launched the hospital indicator system, SciHosp, and they said that the objective was to monitor the performance of hospitals in supplementary health. Now, we're in March 2023. It's been 18 months since the launch. How has SciHosp been doing?
De uma política pública que nós tivemos desde 2011, na realidade. A gente vem construindo a importância da qualidade assistencial, e principalmente a qualidade da prestação de serviços de assistência já há muitos anos. A agência faz um mecanismo de indução da qualidade. Nós conseguimos, em 2021, lançar esse sistema de indicadores, né? E esse sistema vem sendo acompanhado com muito carinho, faz parte do nosso planejamento estratégico da agência. O Brasil tem, assim como o mundo inteiro, nós temos uma de tentar buscar dar transparência e dar informações de qualificação beneficiária, né? Inclusive, a gente, desde 2012, no âmbito do ambiente público, a gente tem a lei de acesso à informação, né? O nosso código de ele é forte em relação à questão do acesso à informação. O problema é que essa informação, do ponto de vista clínico,
Our consumer code is quite good, but the language is still very technical, so it's difficult for lay people. So to put things into context, we were able to set up this platform in 2021, and through this monitoring program, we have been able to receive data at ANS, and the data is calculated for the hospitals who have joined the program. SciHosp is fully operational, and we have 131 general hospitals that have the top-level accreditation. And it's important to say that these hospitals join the program of their own volition. It's completely voluntary. So it also goes to show the effort being made by healthcare leaders to improve quality, information transparency, and governance. 2022 ended in February. The ANS made available the possibility to upload corrected and updated data, and then we are going to issue a report to disclose those results. But we are being very careful with this information because we know that we need this information to be mature, because the most important thing about this process is for hospitals to understand that SciHosp is a management tool that will improve their internal processes so as to ensure better performance. So our intention is that. And in 2022, our agency monitored 14 general indicators, which I will share with you in a minute, 9 out of which are compulsory. These hospitals have to report on 9 of those. So depending on what they do, their level of complexity, they can also send us data about different care lines that are relevant to them. So we have different care lines, and depending on whether each care line is relevant for each hospital, they can report on those. Now, speaking about the technical side of the SciHosp system, it allows people to see indicator results after the system calculates the results. 131 hospitals have access only to their own results. They can see the results per indicator, and they can know whether results have reached the established target for each indicator. They can also get an average of the different indicators across benchmark hospitals so that they can compare themselves with other hospitals across the country. The ANS has access to the results of all the hospitals that participate in the program, and they can also see pooled results per specific category. With regard to the methodology, our hospital quality index data is based on a methodology that aims at quality. So there's a unified score that classifies different organizations based on the results they have reported for each indicator. The methodology follows other international programs and allows indicators to be seen and to help interpret the performance of each organization, because they fall into ranges, and that can be translated into the hospital's global performance. The comparison methodology is available at the ANS portal, and these reports were created and they are disclosed. They include this methodology because they report data that will be turned into metrics so that society in general, especially those who have healthcare plans, can choose their hospitals based on accurate information. Usually they need support to understand the data because it's very technical information. So the objective is to be able to present that information as a summary, and so that it uses a clear and transparent methodology that can generate information that is easily understood by society. Our current management has been looking at the situation very carefully because the Brazilian healthcare system is highly complex. We have many Brazils within one Brazil. And there's always room for improvement when it comes to healthcare. And that's around the globe. We are going through continuous improvement. Since we have different Brazils inside one Brazil, and we want everyone to join the system, right now, we want this tool to be useful to hospital managers so that they can self-assess, compare themselves with benchmark hospitals and the average of all the other hospitals, so that when these indicators are mature enough and the program is mature enough, then we can disclose this data to society at large. In 2023, we'll be working on a public tender to create a system for this comparison methodology, but we'll do that very carefully because we want hospital managers to understand, as I said, that this tool is strategic and that will help them improve their internal process and lead to higher quality. And as a consequence, ANS should be able to ensure the access to information and to disclose accurate and reliable reports with important information to society at large. People can register to join the quality monitoring program. Hospitals can apply The it's available to general hospitals that have the top level accreditation or ANA 1 or ANA 2 certification. So I wanted to not only share the program with you, but I would also like to invite healthcare leaders to join us on this effort so that we can improve governance best practices. Do join our program through the regulatory agency, provide us with high quality information so that we can build a more robust healthcare system and qualified healthcare system in Brazil. We work in three main areas: efficacy, efficiency, and safety. In efficacy, we have vaginal delivery proportion, readmissions within 30 days after discharge, cardiac respiratory arrest among hospital admissions, institutional deaths, venous thromboembolism prophylaxis, and in terms of efficiency, average hospitalization time, average stay at the ER, average waiting room for first care at the ER, prophylaxis, intravenous antibiotics, and in safety, surgical site infection rates, blood flow infections associated to central venous catheters, urinary tract infections associated to catheters. Angelica, I was wondering whether you could summarize this answer, and then we can talk about the rates. Yeah, I'm just about to conclude. Thromboembolism prophylaxis and falls. So those are the main indicators. In our opinion, those indicators can help come up with metrics for Brazil. That's it. Thank you. Yes, of course, this is such an interesting and complex topic that we could be here for hours to talk about everything. Tejal, during her first answer, she mentioned that this data is available, but they're not that easily accessible. And you, Angelica, mentioned that the ANS is also making an effort to compile and summarize this data. You've invited healthcare leaders to join you, but you also said that it can be difficult to disclose this data to people. And we need to remember that we are being watched by patients, and that's precisely what we're trying to do. We're trying to talk about quality and safety indicators for them. So my next question to Claudia is, in the previous panel, we were discussing all of these topics, and in this panel, we'll be talking about data. Could you tell us a little bit about the context? I know that Einstein has a care monitoring unit, and it assesses adverse events to identify opportunities to decrease severe and catastrophic adverse events. And there's a system behind that. So could you tell us about Albert Einstein's hospital journey and the impact it's had? Well, we realized that quality indicators can be measured and they can help us improve healthcare service quality. It can improve safety in patient care, and those indicators can include clinical results, patient satisfaction, and processes. In addition to these, we also have triggers, which are events or situations that point to a potential quality issue or potential safety issue. Those triggers can include adverse events, near misses, patient complaints, or complaints by staff. What we have noticed is that the literature shows that if we are able to capture potential failures, potential adverse events, and based on that, we are able to intervene in real time so as to avoid those failures or those events, we will have a much safer and much more efficient system, and we'll be able to avoid patient harm. So at Albert Einstein Hospital, as soon as we implemented the electronic medical records and care information is made available in real time, we proposed different algorithms that would capture the risk of failures, the risk of adverse events, and then we started monitoring those 24/7 in real time. So at our healthcare monitoring center, there is a team that receives alerts and notifications in real time, and they communicate straight away with the frontline team. The idea is to correct the potential failure or potential adverse event before it affects the patient. I could give you some examples of that. For instance, we have algorithms that can detect if a patient suffering from pain has not received the medication. Another algorithm detects signs of sepsis that have not been identified and if the protocol hasn't been started. We also have algorithms that detect clinical worsening in patients that have not been treated by the team, or a pregnant patient in labor is at risk of having a baby with anoxia or hypoxia, and our algorithms can detect many others. As soon as the team receives the notification, they immediately let the nurses know or the attending physician so that they can deal with that risk, and the team at our monitoring center will be following up on it until the issue is resolved. The idea is to provide support to the team, not to punish, and so we also decided to create a second healthcare safety layer, because we mustn't forget that the healthcare team does many things during their shift, and they might be interrupted. Every time they're interrupted, their level of attention may be compromised. There may also be cognitive failures in healthcare. No one is exempt from that, and that's why we need to have process redundancy. And the monitoring center is one of those redundancies. It helps to monitor the resolution of each case. The Healthcare Monitoring Center also provides support in executing protocols. So if a protocol isn't being followed by any reason, then the monitoring center lets healthcare professionals know. For instance, in the OR, we have an infection, a surgical site infection prevention protocol, and the monitoring center alerts the team about keeping normal glucose levels, normal temperature, the correct use of antibiotics, all very important factors to prevent surgical site infections. And our monitoring center has been of great help to reduce adverse events. An example from the OR, where we were able to achieve 0 catastrophic events. And The monitoring center uses artificial intelligence to help improve quality and safety, improving efficiency, accuracy, diagnostics, treatment plans, and also managing drug administration. It also identifies patterns and trends in the data used to develop and implement interventions aimed at improving patient care based on the identification of a trend of clinical worsening of those patients. Artificial intelligence can be used to assess large sets of clinical data to identify patients that are at high risk for readmission, as we heard earlier. Tejal and Angelica both mentioned that, to identify patients at risk to fall or other adverse events. So that information is used by the monitoring system to come up with interventions that will mitigate and reduce those risks. So, artificial intelligence has the potential to improve healthcare quality and safety significantly, allowing for more accurate diagnostics, treatment, and it also makes easier to identify and to manage potential adverse events.
However, it's very important to stress that artificial intelligence in health has to be used ethically, transparently, and privacy and safety of data of the patients has to be always ensured and protected. Thank you so much, Claudia, especially for mentioning AI. If possible, we could talk for hours on that. So it's quite interesting to see how you are implementing AI in your monitoring central. Is a second layer of safety, as you well mentioned within this context. I would like to ask Vanessa that La Selva talked about the hospital environment, all the indicators, the concern with the processes, the alerts. However, Vanessa, what is the role of the other indicators? Can we go beyond of what happens in the hospital environment? How can we check the quality of life of the patient, which is an important topic? Good morning, Natalia. Good morning, everyone. Thank you for the opportunity. I believe that we have to go beyond the hospital environment. All the indicators that you have been discussing, they have to be available for the patients. We are going to be patients one day, or we have been patients, and it's important to require information, to demand information to be disclosed. Patients very often have no information about what to expect from the procedure they're undergoing. Is there a risk involved or not? Very often, there's no information provided. And one important aspect is the definition of the results. Very often, the results can be seen months after discharge. These are included in the category of patients reported outcome measures. So we have to talk to patients and check the clinical results, quality of life results, which are relevant for the patient. Very often, the patient has arthrosis of the hip, has physical limitations in daily activities, undergoes a surgery, is hospitalized, is discharged for a hip replacement, for example. And what about possible complications? Has the patient returned to the hospital? Hospital stay was longer than expected. What is the level of pain the patient is experiencing after the procedure? And the patient should be informed of what to expect from the procedure and what are the expected outcomes. Beyond the hospital stay, at the Albert Einstein Hospital, we have an outcome monitoring. We monitor patients related to 23 clinical procedures. We apply questionnaires before a surgical procedure and at certain times after the procedure. Very often we follow patients for 10 years. And there is a significant effort to disclose this data, and I'm happy to tell you that today we are launching a report. It's called Value Dossier, and they have 10 specialties included. I'm going to show you a QR code. You can read it, you can have access. And what is the scoring system that we apply for according to the patient's assessment? So this is the first version of this dossier with the intention of publicly making this data available based on four pillars: proper care according to the needs of the patients, timely offering this care. We have clinical outcomes, patients reported outcomes, patient who is discharged is followed. We have a pillar on costs and preventable complications. Claudia and Angelica mentioned these points. And a last pillar, experience and satisfaction of the patient regarding the healthcare services. We are very proud of launching this dossier today, and we hope that this will be a first step for other healthcare institutions to follow. So we have the initiative of the national healthcare system of the Ministry of Health. This is important, and this is a very important movement towards quality. And as you mentioned, it's important to include patients' education. A patient has to be educated to be benefited. Very nice, Vanessa. You, for those who are watching and can read the QR code, which is being shown, and you will have access to all this information mentioned by Vanessa. And I would like to tell you that you can send questions to our panel through the chat box. And it's important. This is a topic which is very important. I would like to ask La Selva one question. We are talking about Excellence Hospital as Albert Einstein Hospital, as Vanessa well explained, that you are in the forefront of disclosing information. And Angelica mentioned that we have different Brazils here in one Brazil. One we have with public health reality, we have the private hospitals, a huge disparity. What about public hospitals with less structure? Can they provide a safe and quality services to to quality and safety levels has to be a target, both for private and public healthcare institutions. The challenges might be, level of challenge might be higher, especially considering the lack of infrastructure, lack of technology, and very often public healthcare institutions deal with higher complexity patients. In this sense, I believe that the contribution, a teamwork between private and public hospitals is crucial, like exchanging knowledge, technology transfer, and even sharing resources. I will give you an example. At our Einstein healthcare system, we have the monitoring health, the monitoring central focused on quality and safety of patients and healthcare professionals through real-time interventions from risk algorithms. And the central is not just active in our Morumbi unit, it's physically located in at our unit, but also acts remotely in a public hospital, Villa Santa Catarina, high complexity hospital, which we are managing, offering treatment for cancer patients. So all the treatments, all interventions available at our Morumbi unit are also available at the Villa Santa Catarina unit. So we act remotely, and the tool was developed and acts through the web. So this is possible. The remote action is possible. Another point regarding public and private institution. It's important to share the best practices, share protocols with the necessary adjustments to each one of the realities. We know that accreditation is mandatory, not just for private institutions, and are already a reality in many public institutions, accredited by ONA, by the Joint Commission, and accreditation uh, establishes a continuous search for higher quality standards, implementation of standards and protocol, creation of targets of quality and safety. So it's creating plans to meet these targets. And as to accreditation, we have obtained the magnet accreditation for nursing services at our Morumbi unit, and I'm very proud to say that we launched our magnet journey this year at our public hospital, Villa Santa Catarina. So this has to be a continuous search towards sharing resources. We had the support of the mayor's office of São Paulo for this magnet journey for the Villa Santa Catarina Hospital. And we know that this is a factor that promotes retention of teams. We have better outcomes for patients and higher level of satisfaction. I could mention many journeys of cooperation between the Albert Einstein Hospital and public institutions or other private institutions, always aiming at improving the quality of services provided. So we have collaborations with different public hospitals, aiming at reduction of nosocomial infections in the ICUs, sharing protocols, training professionals, creating learning opportunities, also other initiatives as maternal mortality reduction during labor, and uh, and also improving quality of in public institutions. I believe that is possible in spite of the high level of challenge, and we can have a strong cooperation between public and private hospitals, generating knowledge, sharing information, and obviously adjusting to each one of the realities. Very good, Claudia. It's good to know that's possible, and it's already a reality in some contexts. So I have a question to Tejão. And considering this context, that this is a journey of transformation. We know that this quality and safety process has to be built. It's a journey going through different steps. So considering this journey, one point that has been mentioned, the previous panel and today's
público, de repente, esses
importance
dados.
of transparency, how important it is to disclose data to the general society. When I ask you the first question, how does it work in the US? You explained that the American government is responsible for disclosing this data. However, they are not that accessible. So I have two questions for you. Was there any kind of resistance from the institutions when the American government started mapping and publishing this data? This is the first. And the second question, what about patients' perception? How do patients perceive quality? Do they understand? How can they interpret the data knowing that one hospital is better than the other?
So the way that the government at least has done that in the US is they have something called star ratings. So they take all these complicated measures and roll them up into, you know, you are a 3-star hospital, a 4-star, a 5-star. So they're trying to simplify it a bit for the consumer or the patient. You know, I think really the best way for so first of all, I do think patients understand quality from their perspective. And I think their perspective is really important, because if we, on our measures, are giving great care, but our patients don't experience that and don't feel that, that can cause emotional harm, that can cause them not to come back for future care if they don't feel that they received high quality care. I think that's been one of our challenges, is that sometimes the clinicians say, well, you know, their clinical outcome was great, they should be happy. But, you know, if their experience was not great, they were treated with disrespect, they were not communicated with clearly, their questions weren't answered, all those kinds of things, that has a real impact on patients. So I think the best way to try to capture the patient perspective that we have right now is through patient experience surveys. And, you know, when I talk about patient experience surveys, especially to doctors and to nurses as well, I make it very clear that patient experience surveys are not, you know, were you happy with the food or were you happy with the parking? Patient experience surveys really reflect quality, safety, and patient-centered care. And, you know, we ask questions like, at discharge, did you understand the plan? You know, were your questions answered? Were you treated with courtesy and respect? Those kinds of concepts, which really do reflect on quality. And so those patient experience data then can be, are what often organizations are using transparently with the public. If you went to my health system where I used to practice and you looked up a doctor's name, patient experience scores are there, and even quotes from patients about what they said about that physician are there. So we're being much more transparent about sharing that kind of data with the public, so they can, and those are very accessible. And so the public starts to get a sense of what other patients said about this particular health system or physician. Now, I will say that that level of transparency, there definitely was pushback from healthcare systems and doctors and nurses that, you know, you're going to put patient comments on the website. You know, there was a fear about that. Though, interestingly, if you really look at the comments, generally, most of the comments are very positive. And so it's actually, you know, a very good thing. And the negative comments are an opportunity for improvement. And we have to put it in that framing that we have to use those comments to drive improvement. So yes, there was pushback, and then some organizations really took the risk and started to do it, and published about it, and sort of showed that the world did not collapse when they put this information there for patients. And it has really become almost the norm now in the US that we start to do that.
Pedro, obrigada por vir.
Pedro, thank you so much. You are coming from the future, telling us how this worked in the US. I would like to hear Vanessa. Vanessa, what is lacking here in Brazil for this to become a reality? Is a culture change? Excellent question. And the question I ask myself, so what is needed for this to become the norm, like in the US? In the US, the government has a significant role implementing the mandatory publication of indicators by hospitals in the Medicare Medicaid system. And obviously, there was a little bit of pushback, but they had no option. They had to publish the data. So I'm not saying that we have to make it mandatory here in Brazil, but maybe this will be the future. The national healthcare system is creating the system of having hospital indicators. This system has to mature because we have to be very careful when we compare indicators between hospitals, because it's difficult to compare different complexity levels. So we might have patients undergoing low complexity procedures, and we cannot compare to other hospital making transplants. So it's difficult to compare our different realities, different set of patients, and the same applies to different complexity hospitals. We saw this difference during the pandemic, the outcomes of patients seen in public healthcare hospitals and private hospitals at first, and the pandemic were quite different. The outcomes were very different. And we have to be careful not to misinterpret the data. We are not comparing exactly the same level of complexity. So the first step is to disclose the information from one hospital to the other hospitals, allowing them to benchmark them, comparing to other institutions. So we have first to reach an agreement of how are we going to disclose the data, and then the next step to make it available for the public at the website of the National Healthcare Authority. And in between, we have a significant movement of each of the hospitals disclosing their indicators. And I believe patients will have a significant role because they can demand, they can require that from the hospitals. So I was discussing with the Leapfrog platform in the US, and it was created by the companies. Companies are sponsors of the system because in the US they felt the need of having these hospital indicators. This platform was created, the healthcare companies created this platform and started disclosing the data. So this is one more step. The general public has to demand this kind of information from healthcare providers. Very good, Vanessa. I have the challenge of managing the time. People are telling me that our time is almost over. So I would like to ask you for your final comments, 1 minute at the most, and thinking of the next steps to how can we better use the available data we have now. Let's start with Angelica. Thank you, Natalia, for the opportunity. Considering information, our website of the National Healthcare Authority has a lot of information. We have indicators of the healthcare providers, of different healthcare insurance plans. And Vanessa hit on the target, because all this data, all these ratings of the healthcare providers, we are getting to a second step. So we will analyze all the data we have, but we have to be concerned with the fairness of how we disclose this data, being careful of not being biased when disclosing this data. So we are being extremely conservative. Assessing this tool, we want this tool to be a management tool, to be useful for managers, for them to be able to benchmark their institutions, and also comparing themselves to the excellence institutions in the country. So stimulating and engaging other institutions in this process. So we want to talk to all stakeholders, identifying how can we improve the analysis of this data, and how can we disclose mature data with disclosing the ranking of the healthcare providers. We have already a ranking, we have an accreditation system of the healthcare providers, and all the information is available at our website. And once again, I would like to thank for this wonderful opportunity of being here, and mention that the vision of the patient is also very important to be included in this process. And as to, we are exactly the official healthcare system is there for the patient, and we are doing this for the patients. So this is an excellent opportunity of improvement, and you can count on us with our support in advancing towards this goal. Thank you, Angelica, for the kind words. Final comments, Tejal, please.
Yes, well, thank you also for inviting me to join today. I will say that during my medical training, I spent 3 months in Brazil, in Vitoria. So I feel very, that is very important for me to try to continue to contribute to help you all on your journey. And I think that is my final comment. This is a journey, and it is a culture change. And, you know, some of the things we did in the US were required, but some of them were really forward-looking organizations like an Einstein, similar types in the US, that really said, you know what, this is the right thing to do, and we're going to do it. And then they brought others along with them by showing that it was possible. And so I think we have to move forward with quality measurement, with bringing the patient voice in, and with transparency. It is a journey, but, you know, if we have the leaders in place who are committed to this, I think it can happen.
Muito, muito obrigada, Tejal. Cláudia?
Thank you very much, Tejal. Claudia, I believe it's quite clear to us. Data can be very powerful, helping us to improve quality and safety, starting from a good system of data collection, allowing us to identify trends, patterns, and potential risk. And the next steps, the implementation of initiatives to improve quality, acting first on the areas of major concern, monitoring the result of the intervention, like safe use of medication errors are still a common cause of harm to patients. We also invest in predictive analysis, identifying patients at risk and preventing any potential harm. And one important point, sharing data among healthcare teams with patients. This helps us to better coordinate healthcare and helps us to reduce risks. Thank you, Claudia. Vanessa? I would like to mention some sources where patients can get information. We have the websites of the hospitals. We are going to publish our value guide at the website of the National Healthcare Agency, ANS. And we have the annual observatory. We have the indicators of the hospitals, and we also have the monitoring of patients' reported outcomes, individualized data by hospital. So we hope that we'll get momentum with this movement for this to continue, and our role is very important because we have to train the healthcare professionals, physicians, nurses, train them how to use this information and how to convey this information to patients. Very often we have very technical teams. However, it's our role to educate the healthcare professionals, helping them to translate results and information for patients. Thank you for this opportunity.
Thank you all. This panel has been very important. There was an immersion into the importance of data, whether it be inside or outside hospitals. Patients should always have easy access to the information so that they can make informed decisions. And as Tejal said, it is a journey and we need to build that. So thank you so much for joining us. And we are back with the third panel of this very rich morning. Fantastic content, an immersion into hospital quality and safety. So far, we have heard from experts who have helped us understand what quality and safety are in hospitals, how they're measured, the importance of indicators, the synergy among teams, patient empowerment, and the importance of providing them with information. We have learned that at all points in a patient journey, quality and safety are key. And in this third panel, we will be speaking specifically about the importance of guaranteeing quality at one of the most critical moments of this journey, surgeries. The needs and challenges of high complexity surgery patients who might need to undergo a transplantation are different to those of a patient undergoing endoscopy, for instance. And those challenges don't only have to do with the specificity of the situation or the status of the patient, but it also has to do with the implementation of technological advances and the qualification of experts on new technologies available. So, on this third panel of this amazing event, I have the pleasure and the honor to welcome Mr. Sidney Kleiner, digestive surgery, coloproctologist, and chairman of Albert Einstein Hospital. I'd also like to welcome Gustavo Odrich, head of endovascular and vascular surgery at Texas University. Welcome also. And I'd also like to welcome Rodrigo Goebel, an intervention radiologist and medical director at Albert Einstein's Interventional Medicine Center, and Dr. Yuman Fong, oncological surgeon and head of the surgery department at City of Hope. Welcome, all of you. So, we have quite a challenge to discuss the context of quality and safety in a surgery setting. So let's start with our international guests. I'd like to hear from you about best practices. So far, we've been talking about the importance of ensuring quality and safety within the hospital setting. Now, when we talk about high complexity, I would imagine that best practices are equally, if not more important. Could you give us an overview of how that has evolved over the years? What does the surgery setting look like? Dr. Fong, over to you.
Obviously, surgery has evolved tremendously over the last 3-4 decades, and we are now doing giant operations at many major centers with very short hospital stays and tremendously good outcomes in terms of mortality, very low mortality for even most complex cases. It is very clear that the higher volume centers will do better at all kinds of surgeries, but it's particularly important for very complex operations such as liver resections, pancreatic resections, esophageal resections. There are also technologically advanced procedures, such as those that are done robotically, such as those that are done with very advanced interventional radiology. And it's very clear that what major hospitals have to do is to do internal audits. We routinely look within our system to see exactly what the outcomes of each surgeon are. And these are compared to their peer surgeons within our same medical system. And the reason this is important is because, again, we want to deliver for our patients the very best care and with the very best outcomes, and to make sure that if there are any hiccups at all, that we iron them out and provide the best care. I know that hospitals like the University of Texas and the Albert Einstein do the same, and that's because most major university and most major hospitals have to do this because most governments are now looking at us. In California state, the data is audited at the state level all the time and reported publicly, and so for us to be sure that we not only do the best for our patients, but report the best data to be ranked amongst the best hospitals, And that's how hospitals like the City of Hope or the University of Texas or Albert Einstein achieve those rankings as the best hospitals in our region, in our country, and in the world, is because the quality within our systems are being audited already by the institution. But I just want to end this section by saying that there are many ways of looking at outcome, and outcomes could could obviously are most important as patient outcomes. Those are complications and mortality, but also important for hospital outcomes, length of stay, trying to make sure that we don't keep the patients longer than we have to, get them back to their loved ones. And cost obviously is very important from a society standpoint and from our health ecosystem standpoint. So again, many measures now that we go by, and good hospitals audit routinely and make sure that our quality stay high. So I think I will hand this over to Gustavo to see what they do at the University of Texas.
Professor Fong, muito obrigado.
Thank you so much, Dr. Fong. I don't know if you're going to ask another question, or I could piggyback on what Dr. Fong has just said. Dr. Gustavo Odrich, Dr. Fong has mentioned many interesting aspects. As he said, major hospitals do that routinely, consistent monitoring. The question I would add on the same subject would be, if we consider that the surgical setting has evolved a lot in the last decades, and so has the technology used in those settings, how much more complexity does that add to safety and quality? Fantastic question, Natalia. So I will answer your question and also add to what Dr. Fong said. To patients listening to us right now, they need to know what we're talking about. What exactly is complexity? High complexity procedures, as the name says, are more difficult procedures. By difficulty, I mean technical difficulties. There is a risk to the patient. Dr. Fong mentioned death, complications. There can also be changes to their quality of life, the follow-up. And an important aspect Dr. Fong mentioned that is key and practically universal at all major centers is monitoring quality data. Here in the US, that's done in many different ways. Most societies already have databases which are thoroughly monitored, and also hospitals have quality databases, and that is extremely important because we need consistent access to outcomes and best practices. We're talking about procedures that also involve a high level of collaboration among specialties, surgery, anesthesia, other experts in other specialties, the nursing team. Another aspect mentioned by Dr. Fong that is important is volume. Obviously, it's universal. When you're talking about high complexity procedures, there is a direct correlation between the quality of outcomes and the volume of those procedures at that center and by that surgeon. It's like I usually say, in Formula One, for instance, why are they able to change the tires in 2 seconds? Because they have a high-performing team. Everyone has a very specific role to play. Everyone has their own purpose, and they're able to do that consistently and perfectly in every single case. Another aspect that Dr. Fong touched on that is important to patients is that things are changing very fast in medicine. What I do now is completely different to what I was trained to do at the beginning of the 2000s. And what I learned during my training are the basic principles of patient care and high monitoring principles, both for the surgeon and for the hospital. It's important to have continuous access and continuous improvement that is data-based, and also including the outcomes. I don't know if I've answered your question, Natalia, but please feel free to guide me if I haven't. No, that's a great introduction to our debate, and we will have a chance to talk more in depth about different topics. So I'll now turn it over to Dr. Kleiner. This is only a first round, and then we can drill down into different topics. Dr. Kleiner, I couldn't start my question without mentioning Albert Einstein's recent achievement. The magazine Newsweek has published Albert Einstein Hospital among the best in the world. Top position in Brazil, top position in Latin America, and 34th around the world. And in our panels, the importance of continuous investment to achieve the best results has been made clear. We've talked about the use of data, AI, monitoring data in the surgical setting, and piggybacking on what Dr. Odrich said, about the fact that what he does now is not the same as he was trained to do. Let's talk about robots. What is the role of that in delivering excellence? How much of that progress has had to do with technology? Thank you so much. Thanks for the question. It's a pleasure to be here with this wonderful people I admire so much. And with you, you ask high-level questions based on your healthcare expertise. I agree fully with Dr. Fong, Dr. Odrich, and it's maybe a generational thing. I was one of the first residents to train on laparoscopy, and that was in 95, 96 at Clínicas Hospital. And since then, our practice has changed. You asked about robotic surgery. Maybe robotic surgery is the biggest and best example of how all the investments in quality and safety have been made in an advantageous technique in most cases, but that can also be risky if a hospital isn't prepared, if the medical team isn't prepared, if you don't have a multidisciplinary team to use robotics. So, Albert Einstein Hospital pioneered this project in Brazil in 2008. The use of robotic surgery at that time, at another hospital, based on the time a procedure took, and there was no deep thrombosis prevention program, a patient left the surgery fine and with a deep venous thrombosis that led to severe complications. So the investment in quality and safety allows technological adoption to be done in such a way that considers, first, what we heard from Professor Fong. It also has to do with outcomes, monitoring outcomes, also the cost to society. Unfortunately, in Brazil, results like they do in the US to be able to rank hospitals and customer experience as well. But when it comes to robotic surgery, when it is well implemented, properly used, and that's what we've been doing over the last decades in Brazil. The different care pathways, or the boundaries we have here. When you talk about volume and quality, Albert Einstein Hospital is probably one of the few around the world where, even though I train to do high complexity pancreas surgery, that is not my area of interest. If I try to perform one, the system will not allow me to do it because I don't have enough volume to justify a good surgical outcome. And we have experts that have the volume to ensure high quality outcomes. So robotics are great when you have the right team, and it also makes sure that both multidisciplinary teams have been qualified to use robotics. And we did all that because we saw the need to have, for instance, in the event of a catastrophic event, how do you deal with a situation of emergency when you have that equipment? For instance, respiratory pathways crisis. Through HCRM, we created an emergency situation if the equipment breaks down. How can we protect patients? That's cultural. There's no point in having 5 or 10 robots working. You have to work on the culture. You have to have the right journey, the right platform to ensure that the culture of quality and safety is part of the hospital. Fantastic. It's great to hear that from you, Dr. Kleiner, because often from the patient's point of view, we see that there's a new technology, and we often think that it's just about using the technology. We never think about all the learning that is behind that, all the audits that are behind that, that hospitals need to comply with, that there are tests. You talked about emergency situations, simulations, systems that will allow physicians to undertake certain procedures or not, depending on their volume and experience. Sometimes that's not clear to patients. Sometimes patients think, well, that technology is available. All you need to do is use that technology. But there are so many procedures and checks and balances behind that. So, Dr. Goebel, I'd like to hear from you about what you think about all these technological aspects. Dr. Kleiner talked about robotic surgery, but I know there are plenty of other technologies that make a difference to the patient. So I'd like to hear from you about that. And if you could also give us some practical examples, that would be great. Thank you, Natalia. Such a pleasure to be part of this panel of titans with such experienced physicians and such high-regarded physicians. I come from an area that used to be known as intervention radiologist, and it is now known as intervention medicine, because we used advanced technologies not only to guide diagnostics, but also for microinvasive or invasive procedures. It's great to hear Dr. Oderick say that what he learned has changed so much in 20 years. And it's true, we have come a long way. There's a huge difference between what we were trained for and what we actually do today. And technology helps us trampoline in our practice with less invasive and less traumatic procedures to the patient. Their hospital stays are shorter, they can go back to their everyday activities faster, and complication rates have decreased as well. So we also have cost-effective ratio to consider. A lot has been said about considering technology per se, and the culture of safety and quality is in the DNA of our service. So just acquiring technology actually doesn't mean that much. Any hospital with a bit of capital can acquire different technologies, but the way that you're going to implement that, the way you're going to use that technology is what makes the difference. Indicators dashboard, that's key. Is it working? Is it not working? Is the team on the same page? Has everyone been trained? Has everyone been retrained? Because what we learned at college doesn't necessarily apply anymore. Robotics is key. Modeling our practice, reducing the risk of inadvertent movements that can lead to patient risk, improving our learning curve. There's a fellow working here with me, and they can learn a lot more quickly using new technologies than we did when we were residents in the 90s. So technologies can accelerate learning if used properly. We also work with international accreditation. You need to pursue high-level accreditation, and your multidisciplinary team has to be on the same page when it comes to these accreditations. So we always try to be up to date with state-of-the-art accreditations and technology. To give an example, we have high-tech that help liver, pancreatic surgeons, as is the case as Dr. Fong, a highly well-regarded surgeon in that area. We can have controlled tumor destruction without needing major incisions, or we can go in to major surgical procedures with the surgeon, and we can tackle the high complex or highly risky parts of the surgery, but always discussing it with a multidisciplinary team. We also have the board discussing it. In oncological cases, for instance, what is the best solution for that specific patient? What is the best alternative for that patient? Technology isn't a hammer, and not everything is a nail. Thank you, Dr. Goebel. And now our next question is to Dr. Fong and Dr. Kleiner. So, considering what you said, that it's not just about having access to technology, it's not just about being able to buy some equipment, it's about training, it's about capacity building. So my question is, up to what point all these innovations that have already been reached and that are part of the hospital setting, what part do they play in the clinical practice itself? How many professionals understand the importance of using those tools in a surgical setting, Dr. Fong?
So, first of all, let me congratulate Dr. Kleiner and the Albert Einstein for the high ranking in Newsweek. That's really quite an accomplishment. But that speaks not only to quality of care. Most hospitals are ranked and well-ranking not just by quality of care, but by the culture of innovation, okay? And so let me explain the difference between a culture of technology and a culture of innovation. Technology is just all the new toys that come on market that are being invented, whether they really work to improve patient care or not. Innovation is really medical professionals like Dr. Kleiner and Goebel and Utterich, who go and look at the technology and say, what will actually make it better for patients? And better is better outcomes, faster or cheaper, okay? That's what I say to my residents and my faculty all the time. It has to be better outcome, faster or cheaper. And robotics certainly has helped us do that. I operate mainly to do liver surgery, and when I do the liver surgery by robotics now, half my patients go home within 48 hours. That would have been unheard of when I graduated from medical school in the 1980s and trained in the 1990s. People weren't even out of the ICU in 48 hours back then. And it really has changed how patients recover, how we go do the work. But then the innovators in general won't just go and adopt it and only make it better for their own patients. They will do like the Albert Einstein. What they have done is really set up a teaching center. That's because those people that are really good in healthcare and in innovation tend to want to teach it so that more and more people can receive the care under the innovation, whether it's at their own hospital or not. And so at the Albert Einstein, They've set up one of the biggest training centers in South America, and I actually believe they are going to be responsible in a big way for bringing robotics to the entire South America. Here in America, I do a lot of training courses with the different societies, and obviously we all write. Part of innovation is really teaching by both papers, books, courses, and training programs, and then setting up centers of excellence for practice and teaching. And so again, I think that what we are obligated to do as leaders in healthcare and innovators in healthcare is really bring not only the technology to our own hospitals, but to the next generation of practitioners in our discipline, and then to go vet the next technologies to say which are truly the next innovations that we need to adopt. So again, really happy to be partnered with all of my colleagues here to do some of that together. Thank you.
Dr. Sidney, eu vou conectar.
Dr. Kleiner, linking to Dr. Fong's answer, he mentioned the culture of innovation, and innovation not just by adopting technologies, the use of promoting the use of robotics in South America. What is the role of excellence centers in this context? Surgeons graduating today, are they already being graduated with this culture of innovation? Excellent question. And Dr. Fong, I admire him, and I'm speaking Portuguese, but we are speaking the same language, because he mentioned the proper adoption of technology with one single goal in mind, which is the quality of care provided to the patient. Dr. Fong mentioned, Gustavo, we are talking about minimally invasive technologies that will result in better outcomes at lower cost and being less aggressive and less invasive, allowing patients to go back to their daily activities very soon. So the culture has to be adopted, and technologies have to be implemented with this in mind. This is the culture of innovation. We see the adoption of technologies, big data, AI, understanding what are the movements that are being made and being used to train new surgeons. Technologies are adopted, however, after this technology is adopted by many professionals. And we at the Albert Einstein Hospital, we know that skills are crucial. And this is why the Albert Einstein Hospital became a center of training, the only one in South America training professionals for head and neck surgery. And in the next months, we'll be providing training to Latin America as a whole. So we will be adding professionals that will be training other physicians as well. So multiplicating this culture, this is a win-win culture, a culture that's constantly reinventing itself, attracting talents, and using this technology to train professionals, to train them properly, to get better outcomes. So our mission is to bring one drop of Einstein to each human being. Thank you so much, Dr. Kleiner. I have a question to Dr. Gustavo. We have talked about the technology, the culture of innovation, the importance of processes, and understanding how medicine, considering that we have technology, we'll have a hire professionals skilled and able to use the technology to result in better outcomes for the patient. However, patients are also changing. Our society is aging. We have a higher number of chronic diseases, and aging itself creates more risk for the patient. How does this affect the practice of surgery, and how is technology applied to help these elderly population of patients and more complex patients, a new profile of patients? How can we connect this to the discussion? Microphone is closed. Natalia, I was listening, Dr. Kleiner, Dr. Fong, and there's not much to add. This discussion has been highly educative. So I will talk about my perspective, my area of work. In the 80s and 90s, patients with aneurysms, with high complex aortic aneurysms, weren't even considered to be candidates for surgery. They had minimal possibilities of surviving. And today, we have been treating elderly patients, advanced age patients with cardiovascular, lung, and renal diseases, which are quite severe. And we can treat them thanks to technology, to minimally invasive technology, and a better understanding of having high performance team. And all these processes that we have in place now are certainly more mature, more developed when compared to the 80s and 90s. I'm talking about quality details, technical details that have evolved significantly during this last couple of decades, allowing us to offer treatment for patients in Dr. Fong's and Dr. Kleiner areas, in my area, offering options for patients who had no option 2 decades ago. And this adds to the complexity of the system, more difficult surgeries involving multiple specialties, state-of-the-art technologies, and surgeries in patients that have a high possibility of complications because of the advanced age. So the possibility of having the optimum outcome, patients being discharged with the functionality rate, which is similar to before surgery, we cannot harm the patients. Perfect. Dr. Fong, do you want to add something considering this new profile of the patient? Dr. Odrich mentioned there's no room anymore for adverse events, and now patients are being offered possibilities they didn't have in the past. And how do these elderly patients add to the complexity of the procedures?
We are certainly operating on sicker and older patients. That is very, very clear. But what that means, though, is that we are offering older and sicker patients a opportunity to recover and to get back to their longer lives. The reason we're operating on older patients is because people are just living older, and we are partly responsible for helping them achieve good quality life at that point. But we're also letting them going home sooner and sooner. And that combination becomes a huge stress on the medical system. How do we make sure that somebody older, possibly sicker, who go home sooner after a big operation remains well? So the next generation of care will need to require remote monitoring of patients. Okay, this is true telemedicine. It is not just an office visit where we are seeing patients by video so that we don't have to have them come to our office. This is true monitoring of patients that have had surgery and are now recovering at home and need our help making sure they remain safe, that they're doing their rehabilitation in a remote way, that they're recovering, and that we are their safeguard by electronic medicine to be sure they are well. And Dr. Kleiner mentioned artificial intelligence. That's where artificial intelligence will come in a big way, because many more patients are going to be sent home with monitoring of not just their vital signs, but steps, but their sugar, glucose levels at home, cortisol levels, and many other things that we can monitor now routinely at home. And by artificial intelligence, we're going to interpret that data and also with the patient-reported symptomatology, and then decide, are they doing just fine and we should leave them alone and let them recover? Do they need to come back to an office or visit earlier? Do we need to call their families and have them go over and check on them? Or do we need to call in the health team to intercede and to have them on the phone? Or do we need to call an ambulance and have them come back? That's all going to be automated, and AI will help us do that. And the best medical centers in the world will have electronic monitoring and true telemedicine in the next few years.
Muito obrigada, Dr. Fong.
Thank you very much, Dr. Fong. I have a question now to Dr. Gobo. Thinking of our audience who is learning a lot from this discussion, important steps related to surgery. I mentioned that very often we see technology and we want to have access to it. However, is not available yet. It's still at the experimental stage. When patients know about technology, when patients ask physicians, what is the role of education of patients regarding technology, aspects of quality and safety? This is crucial considering this context where education and information are widely available, not necessarily is quality information. And this is the role of the decision makers in the health arena, is proper education of the public, of the patients, because the appeal of technology is there. Technology is sexy, extremely attractive. Everyone wants to have access, but not necessarily is an option for that patient. So we, as professionals, as students, of nurses, they have a crucial role in educating our patient population properly, for them to understand what is the best option for them, case by case. Very often patients ask us about not proven technologies. They are still at the marketing stage, not necessarily at the scientific level. And it's up to us to make this distinction. Very good. It's very good to have this explanation, because sometimes we read something about a new procedure, new surgery. So, and patients want to have access. It's important to explain the context. So respecting our time, unfortunately, is short, and we know that you are surgeons, you have surgery scheduled. I would like to ask you for your final comments. And before that, I would like to make your comments considering surgery, high complexity surgeries. What do you think is necessary to advance even more, implementing higher standards of quality? Dr. Gustavo. Natalia, I believe that one crucial point is the coordination between different specialties, because these procedures, we don't have just one single chef or one captain in that plane. We know that uh, I have my expertise, Dr. Funk, Dr. Kleiner, they have their own expertise that are highly valuable, and we need a team effort. Anesthesiologists, nursing team, physicians, surgeons, and this is the differentiating factor when the patient decides to come to the University of Texas, the City of Hope, or Albert Einstein Hospital. This is what they want. They want this coordination. They want to have the support from a team. Excellent, Dr. Gustavo. I would like to give the floor to Dr. Funk.
So just to add to Dr. Odrich, what he just said, we also need quality assurance by audits and transparency of data. And so I've always advocated in the United States for complete transparency of outcomes by individuals and by institutions. And but that's what also the ranking systems of hospitals around the world and around nations actually help us do, is to audit that data and report it to the public. But finally, I also think that it is really a responsibility for all of us at major teaching centers to go and bring innovations forward and try to make them less expensive and more available to all of the patients around the world. And so again, major centers tend to do that, like at the Albert Einstein, the City of Hope, and the University of Texas. And I think we should, and I'm just very happy that we are all working together and allied to go and do this as a mission for all of us.
Muito obrigada, Dr. Fong.
Thank you very much, Dr. Fong. Dr. Gobo. Natalia, whenever we talk about technology, I always remember a quote by Nobel. All technologies implemented in medicine, they have to reduce suffering and to postpone death. So, and we have to remember that all the time. Technologies are advanced and they become something magical. However, physicians have to apply this technology properly. Thank you, Dr. Gobo. Dr. Kleiner, final comments. I believe that this panel was extremely important for patients, and we have to consider the view of the patient as well. Dr. Fong, Dr. Odrich, Dr. Gobo mentioned that this sexy technology and the marketing by the companies, they attract patients. However, not necessarily they will be beneficial for patients. So in certain surgeries, the use of robotic surgery it's not that great if it's not properly used. It's the same like giving an iPhone 14 Pro to a cataract elderly patient, and they won't be able to use the technology. They might be even fall because of the mobile, because they are not seeing. So I believe that organizations trying to provide the best outcomes, they have to inform the patients properly, and they have to use all the resources as to convey understandable information for the patients with proper wording, aiming at benefiting the patient. Dr. Kleiner, or Dr. Odrich, Dr. Funk, Dr. Gobo, I would like to thank all of you for this high quality panel. So leading us to think a little bit beyond the sexy aspect of technology, as Dr. Gobo mentioned, Dr. Kleiner mentioned. We have to understand that we have processes, we have professionals involved, multidisciplinary team, and the importance of the physician-patient relationship. So very much, and we'll be opening the next panel in a few minutes. Thank you so much.
Oi, pessoal, estamos de volta com o nosso...
Hello, everyone. We are back now with the fourth and last panel of this very rich morning with some great content and relevant reflections on safety and quality within the hospital setting. In the previous panel, we talked about the new healthcare challenges considering the profile of new patients. Science plus technology have allowed medicine to transform. That is a fact. At the same time, patients are also changing. You know, the changes in longevity, sedentarism, and that's changed the profile of the population, and it has an impact on diseases such as cancer, cardiovascular disease, and often these patients come to physicians later than they should. Often they have a lot of doubts and are looking for an effective solution. The best outcomes for this patient will depend on a combination of factors. Biologicals, depending on tumor staging in the case of cancer, the availability of treatment, and practical elements. Was the surgery that was conducted well conducted? Has the patient been instructed properly? What is the quality of life of that patient? So how does quality fit within the oncology and cardiology settings? And that's what we're going to discuss in this panel. And it will be the grand finale for our event. I'm very excited to talk to our very special guests. So let's start by welcoming Dr. Fernando Maluf, oncologist, member of the management committee of Albert Einstein's Oncology Center and a member and director of the Oncology Center at BP, Mr. and Dr. Edward Fry, who has just left his position as the chairman of American College of Cardiology and is the current head of cardiovascular services at Ascension, one of the largest private healthcare systems in the US. Dr. Linda Boserman, oncologist, professor, and medical director of the International Medicine Center at City of Hope, and Fernando Bacau, coordinator of the Heart Failure and Transplantation Program, and also VP of Research and Innovation at Albert Einstein Hospital. Welcome. It's a pleasure to have you all here with us. And to start our conversation, I have the first question to Dr. Boserman and Dr. Maluf. We know that treating an oncological patient is not a one-off. They just don't come to you once and never again. It's a long journey involving consulting, appointments, frequent exams, surgical procedures, hospital admissions. The question is, what are the main challenges faced to ensure high quality care to cancer patients, and which practices have helped to ensure more quality and safety to oncological patients? Dr. Boserman?
So, going back to that patient, they hear the word cancer and they freeze, right? We think of the worst outcome. So you need to take that time with your family or your support to find out where you're going to get treated. And that's hard for patients. And so as networks have come together, like Albert Einstein, like City of Hope's partnership with Albert Einstein and then with us, large enough to have all the expertise available and then receive your care as close to home as possible for all the components you can get there. But patients have to know that diagnosis is critical, the foundation of what do they have, the molecular studies on those now, and then the availability of treatment. So first, look for a system that is large and that is networked so that you can have the best of both worlds.
Obrigada, doutora Boserman.
Thank you, Dr. Boserman. And now, Dr. Maluf, could you tell us about the patient journey? How important is it to have those quality elements? Well, I wouldn't say cancer is the only area with those characteristics, but it's definitely one of the main ones. You need to have an impeccable healthcare chain. And the difference and the difficulty to have an advanced oncological center, it has to be impeccable, going from diagnosis all the way through to treatment, post-treatment, which is also extremely important. And as we've heard, when you talk about this excellence network, it plays two roles. First, to provide more efficacy than less complex structures, and to provide safety also. There are many, many papers showing that curing the many tumors and safety in healthcare are very closely related to what we call the volume that goes through that center and the expertise provided at that center. And the second very important characteristic is that regardless of the improvement in treatments due to the chronic aspect, due to the complexity involving drugs, therapies, how long the treatment takes, curing cancer also involves the side effects of the treatments in the short and the long term. So it's key, and centers have been preparing for that, to make sure that we include the psychological element, other elements. We need to make sure that we can give these patients the best we can in terms of ideal functional routine. It doesn't always happen, but this development, the investment in those areas, allow us to go beyond curing the disease, but taking these people to the ideal level. That is the main objective and mission of cancer centers today, I would say. Thank you, Dr. Maluf. And now I have a question to Dr. Fry. In the cardiology setting, we heard from Dr. Bosserman and Dr. Maluf talk about oncology, and I know that you led the American College of Cardiology in the last year, and I'd like to hear from you about those advances in cardiology. How is cardiology seeing safety and quality for patients?
Yes, well, thank you for having me on this program. It's a great pleasure to be with you, and very important topics for patients, for families, for medical professionals as well. So just like in oncology, cardiology has seen an explosion in research, new technologies, new therapies, new ways of approaching disease that we could never have imagined of, even like 10 years ago. And so obviously this is a lot to digest and coordinate. And it becomes even more imperative now that we focus on quality. And quality is certainly drives much of both in terms of the patient's outcome, their safety, and the value of the care that they achieve. And as a population, the value of healthcare that we see as a government or as an insurance system or as a health system. I think the biggest issues around quality really start with having to measure things and record things. So the use of in cardiology, we're very fortunate to have large national databases that we can collect patients' results through national registries. So we can actually have some objective measures of how they are doing. And that also teaches us how then we can modify both the treatment or the approach to patients through process improvement, quality improvement, which is so key both for the individual as well as in population considerations. There's a expression in business that you can't manage what you can't measure. So you have to start with measuring. I would say one of the most important developments in quality management has to do with taking a step back from some of the very technical things that we measure and focusing on what are called patient-reported outcomes. How is the patient perceiving how they're doing? That is so critical. It's fine to say, well, the operation was a success, but you feel terrible. That's not quality. And so we need the patients to really be able to tell us what is quality to them, what has alleviated their symptoms, what has met their expectations. So we're seeing this confluence of the simple, like the reporting of patient reported outcomes, and the complex, the ever-growing technology that we deal with. And I think we're seeing those things come together in approaching quality in a very global fashion for the individual and also at a larger population level.
Excellent comments, Dr. Fry, especially when it comes to that last point. I think we'll have more time to talk about it more in depth, which is the patient's perception. You know, after they leave a procedure, how do they feel? And now I'd like to invite Dr. Bacal to join us in this discussion and tell us a little bit about Albert Einstein Hospital's cardiology program. We know that is well known for myocardial infarction, heart failure, and it's a program that has made a great deal of progress in the last few years when it comes to patient care metrics and comparable to the top levels of the American College of Cardiology, in fact. So I'd like to hear about that journey, Dr. Bacal. How was it, and what has been the impact of that search for excellence in the context of cardiovascular disease? Thank you, Natalia. It's an honor to be taking part in this panel with such experienced colleagues in every single care pathway for cardiological and oncological patients. Albert Einstein Hospital is recognized in many rankings as the top hospital in Latin America. And this history has been built over time. If you can imagine a general hospital with an open medical team implementing managed protocols to standardize conduct, to make sure that the medical team can comply with best practices in patient care for patients staying at the hospital, especially cardiology patients. So these managed programs started in 2005. To give you an idea of the number of myocardial infarctions and heart diseases, there was an international joint commission accreditation, and Albert Einstein Hospital was the first one to achieve that international accreditation, which goes to show how it's always been concerned with safety and quality for such a long time now. And those indicators at the time, let me give you a clear example. Balloon cutting system, which is the time the patient takes when they arrive with acute myocardial infarction to the ER until the time it takes to get to angioplasty and to place the stent or the balloon. At that time, it used to be 90 minutes. Obviously, that was fantastic. Trying to improve that. And over time, and now that time has gone down to 60 minutes. And that's a key indicator. We usually say, if that time is excellent, then all the other quality and safety metrics will probably be positive as a result. So that has led to our international recognition, accreditation by the American College of Cardiology, and high-level results in the treatment. For heart failure, which is a chronic disease for which patients tend to be admitted with high morbid mortalities. We had all the indices in order to be able to provide patients with the best drugs based on international criteria, heart function, pre-discharge guidance. We have improved on all of that. And now, as Dr. Fry said, in cardiology, many things are changing because we're bringing on board new concepts, new technologies, new drugs, and that's also what we are doing with our indicators. There are new drugs that offer a longer and better life to patients. So to summarize, I would say that for those two specific diseases, myocardial infarction and heart failure, for which we have managed protocols, we have a managing nursing team to find cases, to identify the best prescription, post-discharge guidance, follow up on patients after discharge to make sure that there are no readmissions. We've made great progress over the last few years. Of course, there are huge challenges, but without a shadow of a doubt, we are offering these patients in that care pathway for cardiological patients good outcomes and great results, which have been internationally recognized. Thank you, Dr. Bacall, for sharing all of that context with us in this discussion. And now we're going to discuss care coordination. So considering everything we've heard so far from you, especially now what Dr. Bacall mentioned about protocols to have a managing nursing team, that raises a question. Both in oncology and cardiology, patients is seen by many professionals, not just physicians, nurses, nursing technicians, other healthcare professionals that conduct tests and need to be accurate. My question to you is, what is the role of care coordination and what impact does it have on quality and safety? Starting with Dr. Fry, please.
I think you've raised a very important question, and I think the simple answer is whether it's oncology or whether it's cardiology, and both disciplines in particular, it is really a team sport, and both entities, and particularly cardiovascular care, is really built on team-based care delivery. In the analogy of soccer, I'll use soccer instead of American football, where I would use the role of the quarterback, but I'll use the role of the midfielder in soccer as the person who connects the defense and the offense and really helps coordinate the activity of the team. It is essential that there is well-established coordination, that there is somebody at the center who is tying those things together, is the link between the members of the team. And it's not just physicians, it's nurses, it's support staff, it's advanced care providers. In the United States, the use of nurse practitioners and physician assistants as being an integral part of that team. But there has to be somebody who is the glue that holds all that together. That may be a primary physician, a primary cardiologist, say in the care of a complex heart patient, or it could be in the case of other entities, and I'm sure Dr. Bosselman will talk about the role of case coordinators, care coordinators, coordinating oncologic therapies. So you need that sort of network. It gets back to her point earlier that really emphasizes that networks of care, because of the need for team-based care, is very important. It's obviously much more efficient, reliable, the transfer of information much more timely and accurate when that is occurring across a given network of care to deliver a patient's overall treatment plan. So I would I would come back to the importance of the coordination piece and really bringing together all of the attributes of a network to be focused on the outcome of the patient. And to go back to the quality piece, we really should, we're measuring the quality as a function of all of that input. It's, it really is meaningless in measuring just the quality of one particular part of that team, because it really is dependent on what the patient's outcome is, and that's dependent on all of the team performing to their top ability.
Thank you, Dr. Fry. And now a question to Dr. Bosserman, especially in talking about a team and a football team, considering that team structure where everybody has to interact and work with their synergies. The question is, should someone be responsible and accountable for the results of that team? How does that work in practice? Maybe in that interaction with the patient.
You've brought up such a good point for cancer patients, because not only might they have different treatments in different systems, you're often talking about diagnostic information with molecular testing as an essential feature now, that their tumors tested in certain ways, that they see a medical oncologist who may give treatments like chemotherapy or immunotherapy, a team that might give cellular therapy, transplant therapy, specialty surgery between different sites, specialty radiation and supportive services. So there's a growing profession of oncology nurse navigators who are that touch point for the patient. So there are many ways to do it. If a patient's coming to a medical oncologist, they need to know who on that team do they reach out to. Sometimes it's the doctor's cell phone, but more likely now in larger systems, it's a specific nurse navigator who they ask questions to, who then fields it to make sure the entire treatment plan is carried out. So when someone has cancer, you don't just do one thing. There's often a combination of chemo.
Acho que a conexão.
Back to back, and that underlying all that is the supportive care to minimize symptoms and to ensure that people are feeling well and have the support they need throughout that care. So case navigation in the hospital, we have care coordinators that oversee the hospital stays, but the outpatient coordination is generally being done by navigators who are often nurses or other highly trained professionals. And that ties into the quality and the patient satisfaction, but also the staff satisfaction. Staff wants to know that their patient is treated really well and gets all the components of care so they can have the best clinical outcome for the best cost. And that's how we get to value. Value really is the actual quality that the patient got all the treatments they needed, that they were satisfied with it, that it was financially appropriate and had the optimal clinical outcome.
Thank you, Dr. Bosserman. Dr. Maluf, considering the context in Brazil and knowing the importance of that communication among that team that should work as a team, how important is that to the patient? And is it clear that they like having that kind of treatment and follow-up during their journey? You're on mute, doctor. Yes, that is extremely important. I think the first aspect mentioned by Dr. Fry, Dr. Bosserman, and Dr. Bacal said is that the patients have to feel that they are at the center of it all. That's key. I know it seems obvious, but patients don't feel like they're at the center everywhere. And for each situation, for each specific point in the oncological patient's journey, they have to feel that the team is talking, that everyone's talking to each other, and that the team cares about them, and that the team has the right expertise in technical terms and emotional terms to take care of that person. So it's key that, yes, we do need affectionate professionals that are technically qualified, but that are also good in communicating, and that everybody's on the same page, so that when the patient leaves, they feel that everybody's on the same page and treating them the same. And in oncology, there are many different outcomes. You could have a clinical complication, you could have disease progression, you could have severe adverse events. And that's the second step, which is a second or a third team of professionals that will work in coordination with the first team to deal with treatment complications, cancer complications, and to provide continued care to patients who have concluded their treatment. Professionals will work together to allow that person to go back to their everyday lives. So the main messages here are that patients should be at the center, and the teams have to have the right people that treat patients affectionately, that are well informed, that there's multidisciplinarity and communication among the team, so that there are no differences among the same medical team, among the professionals taking care of that patient, so that we have the right safety and efficacy flow, so that depending on the scenario, I would say that if other professionals need to join the case, that they talk to the first care team.
Thank you, Dr. Malouf. I would like to listen Dr. Bacau in cardiology. How important is this coordination of care and how the patient sees that? I agree, I fully agree with everything that has been said. Obviously, we have to have a patient-centered care, and the medical literature is highly consistent in showing that the multidisciplinary team caring for the patient since pre-hospital, hospital stay, and post-discharge, the role of this multidisciplinary team has a significant impact in outcomes, quality, and duration of life. So, quoting the soccer, Pelé was a great player, but he was not the only one. We need a whole team supporting the athletes nutritionally, and we also have to consider the mental health. Mental health is important for cardiac patients, for oncological patients, for primary and secondary prevention. We have to guide the patient. Physical activities is extremely important, even for very severe affected cardiac patients. So we have the heart failure clinics coordinated by nursing personnel managing the patients after the discharge. And we know that this affects mortality rates and reduces rehospitalization rates, and also reduces the global costs of health, because you are better caring for the patient will adhere better to the treatment, will take the medication, will follow the guidance as non-clinical recommendations, losing weight, making physical activity, taking the drugs properly. This also affects the outcomes, and multidisciplinary teams in cardiology are crucial for caring for our patients in this journey, both in prevention and both with established disease. Dr. Bacau, I would like to link another question, to add another question related to quality of life. We know that quality of life is an important metric and has been incorporated in health, not just in assessing new drugs, new medications, is a metric that is gaining value. How is the quality of life measured, not just in excellent centers? Our meeting here, we have just representatives of excellent centers, but what about Brazil in general, other institutions? How is quality of life perceived? Yes, Natalia, if you see the trials in cardiology, testing new drugs, new interventions, when we talk about the outcomes, the endpoints, mortality rates, rehospitalization, quality of life is always included. And this is measured by objective questionnaires you apply before, during, and after treatment. In Minnesota, we have the Minnesota questionnaire, and we have other questionnaires that are applied to prove that the therapy or the procedure has affected the quality of life of the patients. However, in practice, we are always pursuing better quality of life for our patients. We want patients to be productive, to feel well, not being in the hospital. So quality of life is one of the major goals whenever we implement a treatment plan. New medications, new drugs, always assess quality of life, because this is the final goal. People have to feel better. If they feel better, they will be productive, reinserted in society again, and living a better life and with lower mortality rates. So I would like to ask the same question to Dr. Malouf. Dr. Bacau mentioned how important quality of life is. That is a metric that is well consolidated, especially in clinical trials, assessing new treatments. This is a reality also in oncology. But in practice, you mentioned that how important it is to assess survivorship. How is quality of life inserted in this? I believe as the audio is choppy, can you please start again? Natalia, quality of life receives much more attention than in the past. But it has not reached the optimum level yet, because in our office, we ask patients, we ask basic questions. We are excited when we see a CT scan or an MRI showing that the tumor has disappeared. However, I think these metrics can be significantly improved to assess the general quality of life of patients, both oncological or cardiology patients. In my opinion, we have to go deeper into these issues. And we have to understand that the beautiful paths cannot necessarily is translated into happiness for the patient, into good quality of life. So the second point, which is very important, very often in clinical trials, the endpoints are increasing, including quality of life, and they are receiving quality of life is receiving more attention. For you to have an idea, many clinical trial in their clinical trial design, many pharmaceutical companies invite patients to design the clinical trials to help them. For me, as an oncologist, not necessarily the most important endpoint for me is the same important endpoint for the patient. So we have to improve how we assess the welfare of chronic patients, of oncological and cardiological patients. Thank you, Dr. Malalouf. I have a question to Dr. Bosserman and Dr. Fry. I am a journalist specialized in healthcare, and in my interviews, it's quite often people tell me that each case is a case, each patient is a different individual, and we have to customize medicine. Medicine has evolved. Standards, procedures were created, but can we go beyond that? How can we customize patient care and how scalable this is? Here in Brazil, we tell that we have a lot of inequalities, disparities in our public healthcare system here in Brazil. What about the scalable care in oncology and cardiology? This demands a lot of resources. Can we obtain good results from simple measures, Dr. Bosserman?
Getting any simpler. So we've, what is cancer? A cell is not regulated correctly and it grows in ways we don't want it to, right? We know now by testing the genes of the cell compared to the patient's normal, we're asking what is driving that cell. And every day, in some cancers, those specific mutations in a patient's cancer then can be tied to a specific treatment to block that and allow their body to take back over or to shrink the tumor and often in increasing ways cure the cancer. So it's essential that we personalize cancer care for each person, not only who they are, what are their underlying medical illnesses, what is the data, as we've heard from the clinical trials, both on the efficacy. We know it's the safety, but what are those side effects? And that's this process called shared decision making. Often the physician is making that treatment plan and engaging them, but often someone they can talk to then in more detail about why that plan is right for them, why they need an additional biopsy sometimes to get molecular information or a biopsy if there's a recurrence, and then what the treatment options are with specific side effects. And only if we can personalize the care, which is just growing exponentially in opportunity as we find out more about molecular mutations and new treatments, can we develop that custom care plan for each patient. So they're growing, but the decision support that is needed at the bedside is becoming very complicated. Luckily, at a time where we have cloud-based computing, and there are systems now that are pulling down the latest information on the science and the daily changes in genome, genetic mutations in tumors paired with treatments. And there's companies working now to put that in an understandable format at the doctor's and the patient's bedside, and then translate that for patients so they understand why that treatment is the best for them. So this is growing. Is going to be needed. You know, I've practiced breast cancer for 40 years, but I can't remember every new mutation that comes out every day. We have systems and experts helping us to share that not only at the centers, but to everywhere that oncology may be practiced, so that those doctors can share it with patients. That's how we're going to get to quality. And then getting goals of care is a second part of that. What's the patient goal, especially in end of life? Is it to live as long as possible with any possible treatment, no matter how many side effects, or to live well and do some trip or see grandkids or accomplish something? Shared decision-making and goals of care. Individualized treatment plan.
Thank you, Dr. Bosserman. Now, I would like to listen to Dr. Fry about the scalability of treatment within this context of quality and safety.
I think you've already heard some, really fantastic perspectives. I think the issue of clinical shared decision making is very important. However, your question centers around that's at the individual level. So how can we take those practices, best practices related to the individual, and scale that to more and more people, and also vice versa? How can we take the experience from populations and translate it into individualized care? And I think that's where the concept of clinical guidance comes into play within medicine, and particularly cardiology, and I think also in oncology. We have what are called clinical practice guidelines. These are guidelines that tell us really three things. They tell us things that we should do, things that we can do, and then things we should not do. It really boils down into those three types of recommendations based on clinical trials, based on evolving medical science, based on experience of experts that come together and build these consensus documents. And these are not cookbooks with respect to medicine, but rather they are really guideposts, guidelines that tell us, whether something is, very important to do, whether something can be done, or whether this is something that should not be done for the individual. It really sort of applies to 90% of circumstances and maybe doesn't apply to 10% of circumstances. And that's where the art of medicine comes in terms of understanding where a patient's care may fall within these various guidelines and how we apply them. I think it's also really important to remember that patients don't present with a single problem. We know that certainly as people age, they accumulate more and more medical problems, and these problems are interactive. In fact, in the two disciplines that Dr. Bosserman and I deal with, we are now seeing this really back and forth of patients with cancer who are now surviving their cancers and developing heart problems. Or patients who have heart problems who are surviving their cardiology issues and are now developing cancers. And so we have these competing issues that we have to take into account. I think the critical issue is, again, having some objective starting points, whether it's data from clinical registries, whether it's the information from clinical practice guidelines, or what we call appropriate use criteria, places where we know that certain treatments, certain tests are appropriate for a patient's given individual setting, then applying all of those pieces of information in the process of shared clinical decision-making that Dr. Bosserman was referring to. From a scalability standpoint, yes, we can do this, and we have demonstration that doing this in a rigorous way and having continuous process improvement we can demonstrate that we can actually improve the quality of care beyond an individual to groups of patients, to across a whole network of care. We do that in our own system. I'll just close by saying that, a lot of what we do is based on statistics and probabilities. There's a quote by William Osler, who is felt to be sort of the most famous American physician of 100 years ago. And he had a famous quote that said, "Medicine is the science of uncertainty and is the art of probability." And that's really how we practice balancing the individual's uncertainties with the probabilities of things that we learn through science research and data management.
Thank you so much, Dr. Fry, for your answer. I would like to mention one topic and coming to a closing of this panel, technology. There's no way of not talking about technology. Technology is increasingly more present in health through apps, through telemedicine, AI. So my question to you is, what is the role of technology, and I would listen to all of you, in offering a better care for the patient? How can these tools and apps be useful? And I would like to ask you if you already use technology, starting with Dr. Maluf. I believe that this is a very important point. Technology is permeating all areas of medicine and oncology. Technology is already in part of our reality. Artificial intelligence shows that in some types of cancer, some imaging methods are more precise, more accurate, and provide more information. Pathology of prostate cancer, for example, you get to a degree of accuracy of diagnosis much higher than in the past. And you can better monitor patients. You can work with database, you can establish new targets, identify new drugs. So the many advances provided by technology in medicine, also the development of new receptors, CAR T cell treatment. So I think that the next step is the inequity, what I see today, the medicine that we practice today in the excellence islands, our medicine is very restrictive. It's not available. And the general population has no access to the basic health care, not even thinking of technology. So we have to allow technology to be more accessible to a larger number of patients. Thank you, Dr. Maluf. Dr. Bacal, could you please talk about the potential of the use of technology and also your comments about availability of technology? Maluf mentioned a very important point. Technologies are important, however, they have to be accessible, especially considering our country is a continental country, as you call it, as large as a continent, and with a lot of disparities. And obviously, technology has resulted in major advances for arrhythmias, for example. You can identify the patients having an episode of arrhythmia. So it's identified by the watch the patient is wearing. So we have wearable technologies that allow us to monitor the patients 24/7. And telemedicine is amazing, the possibility of seeing the patient and remotely monitoring the patient. Other apps, cardiovascular apps, diet apps. So AI also being used in decision-making processes, not just in imaging, assessing images, but also in clinical decision-making. So this is a new moment, and we have to make this available for the patients. And we have to be concerned, especially considering the inequalities we have here in our country. So we have to be able to provide proper medication. Many patients with chronic diseases here in Brazil, unfortunately, don't get the optimum treatment. This is another challenge. I use technology. I love it. I'm very excited about it, but I would like it to be available to all. Thank you, Dr. Bacon. Same question for Dr. Bosserman. And Dr. Bosserman, do you think technology can help us to improve quality and safety for patients? So using these apps, telemedicine, can we improve quality and safety?
It's gone a long way already, and there's a lot of literature demonstrating that. We were starting, and then COVID pandemic just exponentially got the systems connected and more available. I mean, cell phones are pretty universal, and so for a patient to be able to video or talk with their doctor, or more importantly, to be able to answer questions about symptoms that are common when they're on treatment, that are immediately connected to a triage nurse who then can call them. Symptoms on Monday, and you treat them instead of having people come to the hospital sick on Friday. So being able to respond in real time to patients whose courses you want them to get the right treatment, but managing that treatment, keeping them out of the hospital, out of the emergency room. When a cancer patient goes to the emergency room, they look sick and they get admitted. We're very comfortable treating them as an outpatient, keeping them healthier and with their family, but we'd like to do it on Monday and not on Friday, or whatever day of the week. It might be on Saturday instead of waiting till the clinic opens on Monday. So technology is this on the apps, on wearables now, they can monitor heart function and temperature and see early onsets of infection before it happens. Also having patients connected to their electronic record, so they know their treatment plan, they know their schedule, they know when to have labs. Nurses know when to call and when to interact with them, and we can actively triage and we can collect their symptoms to start looking at trends. Are they having more nausea when you adjust the medicines? Are they having pain? Are they having mouth sores or potential swelling? So we can much more personally and immediately the health of that patient, help them stay on their care plan so that ultimately they can get the best treatment outcome, even if we have to adjust that care plan. So I think technology lets us reach far away. It lets us also connect to clinicians. I worked with rural physicians who had to take care of cancer patients. I sent the orders, I monitored on the phone with the doctors, but that patient saved 8 and 10 hours of travel and could get the right care, but through a local physician. So technology allows us many ways to work with the patient and the patient's care team to coordinate the same level of care the street from a big center. It's an exciting time.
Yes, exciting times, really, I agree. Dr. Fry, your comments on the role of technology and how can we connect this to quality and safety?
Points have been made. I think the important concept is to realize that in all technologies that we're now leveraging within delivering care is the ones that are most successful are ones that are amplifying the role of the human caregiver. So it's really, we talk about artificial intelligence. We like to think of new technologies really as collaborative intelligence. So things that help us collaboratively do a better job in terms of the traditional things that we do. But I think at a basic level, so what can technology do to improve delivery of care? Number one, as has been pointed out, is access, simply being able to connect to the health system. Number two, the coordination of care. We've heard about, somebody develops a complication. How can we manage that in a very rapid fashion? Thirdly is using these well-established clinical practice guidelines and being able to apply them to individuals directly by using technology by way of communication, enhancing the patient's experience, not having to wait, delaying the wait times for treatment and those sorts of things are a direct benefit of technology. And then lastly, as Dr. Bakal had pointed out, are closing these disparities, closing the disparities of care that we know happen all over the world, whether it's based on education, whether it's based on people's economic status, whether it's based on social disparities, that technology can close these gaps. It also empowers the patient. It also turns the table from what in the past had been a very sort of top-down model of care delivery to one that is bottom-up, where the patient can initiate many of the things that need to be addressed with their caregiver rather than waiting for that more traditional patient-physician interaction. So great opportunities ahead, and I think we will see this increase quality of care, increase value, lower cost of care despite the cost of technology. I think the return on investment will be huge. And for countries like Brazil, where you have such immense geography to deal with and such disparities to deal with, I think the improvement overall of national health will be significant.
I would like to thank Dr. Fry, Dr. Maluf, Dr. Bosserman, Dr. Bakal. It was a very enriching panel. We learned a lot. The points, food for thought about this new context, understanding the role of technology in cardiology and oncology. And certainly, if we repeat this panel next year, we have many new topics to discuss. Unfortunately, we have to adjourn this meeting. This was an amazing morning. Not just this panel, all these panels were amazing, a lot of learning, a lot of food for thoughts, especially considering Dr. Fry's quote of health is a team sport. We have to have all players aligned, aiming to meet the goals. So quality and safety is not just an issue of wanting, of will. It's a process, it's a journey involving a lot of people, is related to information, training, and listening to the patient. And our discussion was geared towards listening to patients. And we cannot forget that here in Brazil, we have to change this culture, how we see safety and quality So this meeting, I believe, will start a new era in the healthcare provided by Brazilian institutions, the new culture of listening, engaging the patients. So thank you all very much. I would like to thank Albert Einstein Hospital for organizing this meeting. Thank you for the honor of chairing this session, and thank you to all the professionals involved. Thank you so much. Have a nice day.